and welcome to our online audience, which is increasing in number as our meetings go on. We have one apology for absence from Annie Laverty, Executive Director of Improvement and Experience. And this would have been Annie's last meeting of the board because she's leaving her post. So we pass our best wishes and thanks on to her. Question of quoracy now. I always feel a bit like Schrodinger's cat in this position, hanging between quorate and non-quorate until somebody tells me which side of the fence we're on. So are we quorate?
We are, yes.
Good. Thank you. So that's an end to any quantum physics being mentioned in the meeting. Declarations of interest then. We have our pre-existing statements of declaration, and then for the item on primary care 10.4, 3 members of the board, Sarah Malik, Neil O'Brien and Mike Smith, are all involved in primary care. So technically there is a conflict of interest, but we're not taking any financial decisions, so they're free to join in the discussion that we'll be having on that item. Minutes of the meeting held on the 26th of September, our last meeting. Are there any points of accuracy there that anyone wants to raise? There are not, so we move on to item 7, the action log, which essentially are the matters arising which required follow-up action or monitoring. Are there any updates any of the executive directors want to raise with respect to the action log? Yeah. Okay, thank you. Any points anyone wants to raise on the action log? Thank you. And then the minutes of the annual general meeting held on the 26th of September 2023. Are people happy that these are an accurate record of the annual general meeting? Thank you. And then a particular action which is flagged up under item 7.1, the position on neonatology, and we'll ask our Executive Director of Nursing, David Perdue, to respond to that.
Thank you, Sir Liam. So as part of our Ockenden reviews, we've done peer reviews of all of our maternity and neonatal services across the 8 providers, and we have a learning event on the 2nd of February to see what was best practice and share across the system. There was nothing flagged up particularly from those visits, but we have conducted a peer review visit of the Newcastle hospitals in relation to their Embrace data and them being an outlier for infant mortality. Now that Embrace data does look at all providers who provide a level 3 neonatal unit with surgery, so they are very different across the country. And there are only a small number of organisations who undertake congenital work, and Newcastle being one of those. But even if we take out its congenital work, it is still a 5% outlier. We are doing some work with Embrace nationally to compare like with like. So we're looking at ensuring that organisations like Leeds, Sheffield, Manchester, we compare them to each other. But following the meeting that we've had in our peer review, we are going to do some joint peer reviews with Leeds and Sheffield, just as a comparator. The 3 areas that we found on that review that needed immediate attention, one was around they have a bay in the unit which had no emergency call buzzer. So that was flagged straight away and mitigations put into place. We are confident that the mitigations manage the situation. There is something around their governance processes in terms of SI reporting, and we're doing an independent review of that. And then finally, staffing. So they do have staff in place, they're over-established, but it is the level and competency of some of those staff to manage the situation. They have 38 cots in Newcastle, and they were supposed to open an additional 4 in October due to pathway changes from South Tyneside and Sunderland Trust. They haven't been able to open those beds yet, those cots yet, but there is a plan to open those in January. So we're working with the Trust in terms of its workforce plan.
Thank you, David. Anybody want to raise any questions or points with David? No, thank you very much then, David, and move on to the Chief Executive's report from our Chief Executive, Sam Allen.
Thank you very much, Chair, and good morning, everybody. I just want to start by saying it is a real privilege to be appointed as Chair of the National Maternity and Neonatal Programme Delivery Board, and delighted to take up that responsibility. I will chair the first of those boards next month, and we'll be working closely with the team delivering the 3-year delivery plan at NHS England for maternity and neonatal services. I'm really looking forward to taking an improvement approach to that programme. You will have seen that a significant amount of the work is around the culture of services, but also working very closely with families and also clinicians and professionals working across those services. That is an additional responsibility I'm going to be doing alongside my role here in the ICB. It has been an incredibly busy time for services. In spite of the weather just starting to dip in temperature, we have seen a noticeable increase in demand through our acute and emergency services, and indeed that would have been felt by general practice and of course our voluntary and community sector partners as well. I'm pleased over the last day to hear that there appears to be progress with regard to industrial action, which, as you'll be aware, has been paused to enable talks to happen. And I was pleased that NHS England were able to allocate out to systems additional funding to meet the cost of that industrial action over the past year. And like all of the other 41 ICBs, we've been working very hard with all of our NHS trusts over the last couple of weeks to revisit our plans, particularly for urgent and emergency care, but also our financial plan. You will know that this year we agreed a deficit plan with NHS England of just under £50 million. We did meet with NHS England yesterday to present the work that we've done over the last couple of weeks, and indeed we held an extraordinary board meeting as requested last week to sign off on a revised financial forecast for this year, which has been agreed as a £35 million deficit. So with the additional money coming into the system, we do feel that we can improve our financial plan this year. We will continue to work hard, and where we can strive towards a break-even plan, we absolutely will do. However, we think it is realistic of us to agree that £35 million deficit plan, and that's has been supported by NHS England, and our finance Director, David Chandler, I'm sure will comment later on in his finance report on this, Chair. Alongside the revised financial plan, we were issued with very clear guidance that the priority, certainly over the next few months, has been to prioritise urgent and emergency care, and also the elective recovery plan and cancer care. While still above the national trajectory on cancer, we certainly have more to do in that area, and we indeed have more to do if we're to hit our ambition of having 0 78-week waits for elective care and reduce the number of people waiting over 65 weeks for elective care. It'd be fair to say we have continued to make progress in those areas, but it has been impacted by the industrial action. And Jacqueline Myers, our Director of Strategy and Operations, will certainly cover some of that through the integrated performance report. Alongside all of this, again, like other ICBs, we are in the midst of our running cost reduction. So that target for us was reducing our running costs by just under £18 million. And we are out to consult with our organisation at this point in time on revised structure. And that does include fewer jobs than we have today across the Integrated Care Board. We are taking this opportunity, particularly on the back of bringing the ICB together from 8 predecessor organisations, also to address issues around equity, reduced duplication. Notwithstanding that, this is a significant change, both for our staff and also our partners that we work with. So we will continue to support our staff through this process and also reduce, insofar as we can, the likelihood of any compulsory redundancies. It would be also remiss if I didn't mention the impact on our commissioning support unit, the North East Commissioning Support Unit, who are also out to consult with their staff to reduce the amount of support we give them by 30% as well. We are working closely with our staff side chairs. I do just want to note that we have participated this year for the first time in the annual NHS staff survey. That survey has been undertaken in the midst of this significant organisational change, and I do anticipate when we look at the results next year that we'll see that reflected in the results and feedback from our staff. We do continue to support our staff through this, and we do have a variety of support package in place for our staff, including access to employee wellbeing support, coaching support, and also personal advice with regard to careers and coaching. I am confident that we will deliver the national target for the running cost reduction. However, we also will have to embed our new way of working right across the ICB, and that will take some time. I'm delighted, Chair, that we have got our system leadership group off the ground, and that meets formally for the first time this week. We have undertaken work as a group of system leaders working in health and local government over the last couple of months, supported by Sir David Pearson, and that's been well attended by partner members, and our VCSE partners will also be represented in that system leadership group. The three areas that we've agreed that we will focus on working right across North East North Cumbria will be children and young people, including children in poverty, system leadership, so supporting leaders right across public services here in North East and North Cumbria, and also the opportunities that we have on our workforce. And we do have our workforce strategy in draft, nearing completion, and we'll be considering that at our meeting this week. There's been some changes in our system, so we have one new chief executive appointed for the Teesside group, North Tees and Hartlepool, and South Tees Trust, and Stacey Hunter will join the system from Salisbury at the end of January. Stacey has already been spending time in both of the organisations getting up to speed, and she will be the single chief executive working with a single chair across both those organisations. We look forward to welcoming Stacey, as I know our provider collaborative will do so too. And colleagues will know that Sir James Mackey, the current Chief Executive of Northumbria Trust, has been appointed to take up the post in Newcastle, and Northumbria are interviewing for their Chief Executive post in December. I do, Chair, just want to touch on our two foundation trusts, particularly from a CQC perspective. The Newcastle upon Tyne Hospital's NHS Foundation Trust is, as we've reported here previously, we do have a quality improvement group in place for oversight of the organisation. The deadline for submission of the Trust comments on their draft CQC report is today, so we hope in the next few weeks to get an update on when the publication of the CQC report. We do know that the Trust has had their rating suspended. When that happens, it is a strong indicator of the likelihood that there will be a significant change in the rating of the organisation. And we know that this is an organisation that's been rated outstanding for the last several years. We do meet with the Trust regularly through a formal quality improvement group that I chair. We have oversight of all of the actions in place across the organisation, and we're working closely with the NHSE regional team, the Trust Board in Newcastle Hospitals Trust. So James Mackey is the incoming Chief Executive of the organisation and the CQC. I was pleased to see the Tees Weir Valley CQC report published and the notable improvement that they have made since the last CQC inspection. Whilst they're still rated requires improvement, there were a number of improvements that are noted within the report. There are also areas that require ongoing attention, and the one area I do want to particularly highlight, Chair, it's included on page 5 of my report. In fact, there is a slight typo in the report. Series should read serious, was the backlog in serious incidents at the Trust. I know the Trust understand that that's unacceptable. It has been unacceptable. They have been working through that backlog of serious incidents with the support of the ICB and the regional team, and we have had a long-standing quality improvement in board in place with the organisation. I was very pleased to see the improvement in the nursing posts. There's a 27% increase in qualified nursing posts in the Trust, notwithstanding the fact, though, that this is the organisation that still has the highest agency use in place across our system. So whilst there are improvements made, there is some way to go, and we will continue to support the Trust with the work that they're undertaking. And then just finally, the report for Northumbria Care was published, the North Cumbria Integrated Care, and again, that recognised sustainability from a quality perspective and some ongoing improvement work, which will continue to support that particular organisation with. I'm pleased the North East Ambulance Service has had their first independently chaired oversight group following the publication of the report authored by Dame Marianne Griffiths. The purpose of that group is to absolutely ensure that the recommendations are fully implemented, and we will receive an update on that, Chair, in the spring, and the ICB Quality Committee is maintaining oversight of how that work is progressing. I won't go into detail on this, but my report does cover the priority areas of focus for winter. I'm also pleased to say that working closely with our local authorities, and my thanks to our ICB colleagues working in our place teams, all of our Better Care Fund plans have been signed off and agreed locally by Health and Wellbeing boards and also nationally by NHS England. I'm delighted, Chair, to include in my report an update on women's health. So you will know that the first ever women's health strategy was published by government, and the £25 million that was allocated nationally for this was distributed across ICBs. You'll know from my previous comments on this, I was disappointed that that was allocated, wasn't allocated on an equitable basis in terms of the size of the ICBs, but notwithstanding that, we did receive £550,000. And later today, as an ICB, we will announce the first 3 projects that we are supporting for the creation of women's health hubs across the North East and North Cumbria, and they will be in Sunderland, Gateshead and North Cumbria, and we look forward to getting the learning from those women's health hubs in order to spread that. We had an incredibly well attended women's health conference hosted in Sunderland. We had the Women's Health Ambassador for England attend, Dame Leslie Regan, and Dame Leslie Regan has committed to attend one of our integrated care boards next year, where we'll be reporting on women's health. We know that so many of women's health services that we provide now could be better provided if they were provided in a more joined up and coordinated way, and not all of that requires funding. So I'm looking forward to getting the learning out of the first 3 hubs to see what we can do to better join up women's health and indeed improve the health outcomes for women across our system. And then, Chair, it has been an incredibly busy period. There's a few other things I just want to cover. You may have seen last week, Professor Chris Ham published a report on learning systems. We were one of several integrated care systems across England that featured quite heavily in that report for our work on Boost, which is included in my paper today. Boost is the North East and North Cumbria Learning and Improvement System. It builds on a very strong history here in the North East and North Cumbria of the North East Transformation System, and also the Cumbria Learning and Improvement Community, CLIC. We launched Boost this month. We already have 6,500 members of our learning and improvement community. Anybody can sign up to join Boost. A member of the public, a member of staff in health, care services, voluntary and community sector services, independent sector services, in education and academia. And indeed, we've drawn members from across the world. The learning improvement community is a really rich resource of lived experience, professional experience, and we'll be wanting to nurture and grow this community. I'd really recommend all members of the board go online, have a look at the Boost site and see the type of work that's already been generated through this community. It will also be the sort of central learning portal for us as a health and care system. When I joined the system now nearly 2 years ago, one of the very strong messages across all of our partners in the system was there was much more we could do to learn together, to share what we're doing, to share the good practice. And when you look at that website, you'll see how teams across our system are visiting each other, they're undertaking peer reviews, and we're also running online sessions. I would highly commend you to look at the session on what's called the Liberated Method, which has been delivered by a director from Gateshead Council, Mark Smith, to get a really good insight in the type of innovative work that we're generating here in the North East, North Cumbria, and aiming to share not just locally but nationally and internationally. And as part of Boost, we held our first Children Young People's Mental Health Summit, and working again with nearly 300 people in that room, and that was led by many colleagues in this room. And I particularly want to thank Levi Buckley, Annie Laverty, Kath McAvoy-Carr for their support on this. But working across that learning and improvement community, we've identified our big 5 ideas to take forward, and we'll be progressing those and updating the board. And then just a couple of things just to finish off sharing. I do want to share a reflection on personal health budgets and listening to families. Probably about several months ago, I was contacted by a group of families in the north of our health and care system. And this group of families are all caring for people, members of their families, who are in receipt of personal health budgets, sometimes with quite complex health and care needs. And personal health budgets, as you know, are something that are available to people to put in place their own care support. They can quite simply, for some people, be the difference from a more institutionalised care setting, very dependent on health and social care, to living a more independent life with their own carers' support in the most appropriate environment. I met a group of families that didn't feel that they had been listened to. I met a group of families that had raised concerns over many years about their experience of personal health budgets and the challenges that they were experiencing. And working with the team in the ICB, we have put in place a whole programme of work now around personal health budgets. That has started with a baseline assessment of how we do personal health budgets across the North East, North Cumbria. And it'd be fair to say, and again, this is based on a lot of legacy and historical arrangements, there are very different arrangements in place in each area we've gone to see, and we do have quite a lot of work to do. We will continue to work with this group of families. They've offered their time generously. They'll be offering their experience to help shape the work that we do. And David Purdue, our chief nurse, will head this up through our continuing healthcare. And for me, my thanks go to the families, because whilst we know that the ICB has inherited a lot of legacy systems and different ways of doing things, which is inevitable given we inherited 8 organisations across a very large area, I'm not sure if it hadn't been for these families we would have spotted the types of issues and concerns they were experiencing. So I'm personally very grateful to them for sharing their experience with us. And Chair, you'll see in the paper a brief update on gender pay gap and the ethnicity pay gap. As an ICB, because we now employ more than 250 people, we will be required to report formally on the gender pay gap next year. But in doing the gender pay gap, I also think it's important we look at what's called the ethnicity pay gap. And we have now undertaken this piece of work, and there is quite a bit of work to do in order to determine what actions we need to address, particularly around reducing the pay gap, the gender pay gap and the ethnicity pay gap. And we'll bring the report back to board in the spring next year that sets out our plan to do that.
Thank you, Sam. It's a very comprehensive report. Are there any points anyone wants to raise, questions? Yes, please, David.
Sam, you mentioned the women's health budget. I think you said 25 million nationally. And if my maths are right, we should have received on fair shares about 1.25 million of that. And I wonder whether you said you were disappointed on the allocation, I'm not surprised. Do you actually know, and you may not be able to answer this, what the actual basis of allocation was? And are there any lessons to be learned for us in that?
I do, because alongside two other large ICBs, I did write to the Minister, the Department of Health and Social Care, about this, to raise this issue. The Minister, I think, took a decision that the initial tranche of funding was to promote the establishment of hubs to set up and learn from, and therefore the 545,000, I believe it is, was predominantly around set-up costs. I personally think that we needed to raise that formally, because if we look at the size of ICBs, they vary from providing support to a population of anywhere between 300,000 to over 3 million like ours. And therefore, even if you're looking at infrastructure costs, particularly in the face of running cost reductions, I do believe we need to look at fair shares. For me, the learning is around allocation across national schemes. And if decisions continue to be made where funding is not allocated on a fair shares equitable basis based on the size of the population, the North East North Cumbria will continue to lose out, and that won't be acceptable. And I think we need to be very vigilant about this, particularly when funding streams are allocated nationally.
Thanks, Sam. I'm very pleased you actually raised this with the Minister. Thank you very much.
Thank you. Kath McAvoy-Carl.
Thanks, Sam. Just a couple of points. One is around personal budgets, and it's an area that we are particularly interested in from a local authority perspective. So I feel like I'm a little bit of a broken record. So I'm hopeful that there'll be some partner agency involvement in that work that it is undergoing.
Yeah, Kath, there is absolutely, and we have got representation from local authorities. So if you want to be included, you're always
that would
very
be
welcome.
lovely. Thank you. Thank you. I don't know how I've ended up with an additional task. And then the other issue is just to reiterate my plea around the reorganisation to make sure that the statutory organisations, the statutory partnerships that we have are appropriately factored into that issue. So thank you.
Thank you. Eileen Kaner.
Yeah, it's back on the women's health issue. I was really pleased to be part of the process of looking through some of the applications. I share your view that the allocation was not as much as we required, and I hope for more in the future. But my point is that often women's health is synonymous with women's reproductive health. And what I was quite interested in to see applications that went beyond just the provision of reproductive services, to think about different kinds of women and different kinds of health and wellbeing needs, including mental health. So I'd really welcome the learning from the initial setup, but really looking at the integrated health hubs to address issues beyond access to reproduction and reproductive health care. And I think the other thing really is also to think about girls, women to be, because I think their health needs and their mental health needs are often overlooked, and they are, you know, at a very, very formative stage about starting to develop their reproductive preferences and choices. So I didn't see an awful lot on girls, so I was hoping for more, and I really wanted to see at least later phases of initial plans to go beyond just the provision and access to reproductive contraception and other forms of reproductive control.
Thank you, Eileen, and absolutely noted. And the women's health strategy is throughout the whole of the life course, so it is women and girls, and much more than just those reproductive years where, you know, if Leslie Regan was here, she'd be saying that's historically kind of what the way we've looked at women's healthcare and the way services have been designed around women's healthcare, but it is absolutely through the life course. And I would agree, I think this is just a starting point and we can really grow this. And I should have also said that Claire Riley is our executive lead on women's health and may want to add to this.
Yeah, just to add, thanks for that, Eileen. We are actually developing an implementation plan that will come back to the board in the new year, which will include exactly as you suggest, Eileen. And realistically, if you look at the women's health strategy that was published by government, they talk about the cost-benefit analysis linked to every pound saves £5 overall in health services. So what we need to do is really look at the provision of services, how they link together, but also recognise there is also a cost-benefit of analysis of getting this right and doing this well.
Okay, well, sorry, Sam, you want to comment again? Yes.
Yes, sorry, Chair. Just two other things I omitted. I also want to, it's being announced today, the appointment of Professor Dean Fathers as the new chair of the Health Innovation Network, formerly the Academic Health Science Network. And I want to welcome Dean to the region. And I also should have mentioned that yesterday I was in Sunderland with Ken, the Chief Executive of Sunderland South Tyneside, who's here today, marking the start of the construction of the Sunderland Eye Hospital. This is going to be an absolutely world-class facility located in Sunderland and certainly serving the region. And it was a real pleasure to be there. And I do want to really acknowledge not just the hard work of Ken and his leadership and his team, but also to thank our partners at Sunderland City Council for their support that have enabled us to, from an NHS perspective, build such a brilliant facility here for our population, and look forward to its opening in a couple of years, Ken.
It's a very welcome piece of news, because when I was here before as regional director, we set up the first fast-track cataract centre in the country in Sunderland. So Sunderland's very much been the lead on eye surgery over the years, and it's wonderful to see this further development coming in. Can I ask Sam, and you might want to ask Neil O'Brien, our Executive Medical Director, to deal with some of this. Winter, we're all aware, I think, of the extensive preparations that have gone on, but I wonder if there's a feel yet for the probably what will trigger whether winter is easy to handle or difficult to handle, the pattern of viruses that are emerging, COVID, flu, respiratory syncytial virus, and in some parts of the country, outbreaks of measles affecting children. So I just wondered if there's any emerging evidence really of how the viruses are going to behave this winter.
Yeah, thanks, Chair. So what we do know is that COVID numbers have had an early peak, and they've certainly been rising probably over the last probably 4 weeks. But if that pattern continues as it has in previous years, we'll likely get another peak, probably about another 4 to 6 weeks down the line. There was a lot of concern around the effect on people's health of the current circulating COVID virus, whether or not that would have severe impacts on people's health, but that doesn't appear to be the case. Admissions to hospital are increasing at a level that you would expect, but not accelerating. Flu, there's no reports of large numbers of circulating flu virus at this time, but obviously that's under that's under constant review. And RSV, there has been some increased numbers of RSV circulating in the community, but again, not anything out of the ordinary that we would expect. So at the minute, it's very careful observation, and it'll continue to be monitored through the winter. We do know that there is quite a lot of pressure from general respiratory illness, which is coming through our emergency departments and our general practices in order to try and support the entire community with those increasing numbers. We are looking to set up a number of acute respiratory illness hubs in all of our places, and they should become operational within the next couple of weeks, and they'll continue throughout the whole winter just to try and support the system in dealing with those that expected increased number.
Okay, thank you very much. And thank you, Sam, for your report. And we'll press on now to the next item, which is the Board Assurance Framework. And Claire Riley, our Executive Director of Corporate Governance, Communications and Involvement, is going to deal with that. And on this item, we're required to satisfy ourselves that the report accurately reflects the principal risks to achieving our objectives as well as current mitigations. And then after listening to Claire and raising any points, to consider whether we wish to approve the report.
Thank you, Chair. Hopefully board members will be familiar with this report. This is a living document. It evolves every time we bring it, dependent on the risks that come through. This is, as the Chairman has already said, to provide assurance to the board on the management of our key risks. You will see that we have aligned those key risks to our better health and wellbeing for all key goals. And hopefully you can see the golden thread from our strategy through to how we are managing our risks, and you can also see the mitigations that are put in place as a result too. You will also see the detailed corporate risk register behind the board assurance framework, and it provides you with a wealth of information. I'm happy to answer any questions, Chair, but hopefully the board are minded to approve this document.
Okay, any questions or comments? Yes, Mike Smith.
Thanks, Claire. This iteration of the document is excellent, and the golden thread is really clear, and the alignment to the strategy is really useful. I guess what's concerning is that when we look at the scores and the current trajectory where we're off target in most areas, is there any optimism that at some point we're likely to regain target? I appreciate there's an awful lot of mitigations and work going on to try and overcome these things, but some of the very honest examples of why we're off target in various different areas don't seem easily overcome in the short term, at least, or even sometimes in the medium or longer term. I just wondered what your thoughts were on that.
I suppose it depends on the risk that you're referring to, Mike, and obviously this links to the corporate risk register that my colleagues obviously input into. And if the risk is linked to clinical, obviously Neil will have that detail, or David. If it links to broader performance, Jacqueline will have that information. I think overall, this is a fair reflection of where we think we are as an organisation and as a system linked to our key strategy goals. And they are informed by an assessment based on where we are with regards to our activity. So unless you can specify necessarily what area you want to go into.
So no, it wasn't to bring up any specific indicator. It was just that taken in totality, lots of the indicators are in the red or in the orange, and that's, I guess, a concern as to whether we're likely to meet the goals that we've set ourselves as an organisation.
Yeah, I think, again, this reflects the reporting that our execs do. I can't necessarily brief you on where we are with regards to hitting targets, but from a finance point of view, David will be able to give you a position, and that reflects in the paper that's already on the agenda, Mike.
And our board secretary comment.
Yeah, thank you, Chair. It was just to say that we have just agreed our risk appetite. As you know, we did some work with the board, and on the back of that, we will be doing further work with the risk owners, particularly around target risk, to make sure that they do reflect that appetite, but also that the proper mitigating actions are in place. Because I think I do take your point that some of them aren't quite to the target just yet, but I think once we've done that piece of work over the coming months, hopefully you'll see the difference.
Thank you. Are there any other comments? David, you looked as if you were about to put your flag up, but go ahead.
Yeah, thank you.
David Chandler.
Thank you, Sir Liam. So I will touch on the finance update, but there is some good news on some of the financial risks that we're actively managing at this moment in time. So if you're okay to hold your horses till then, I'll happily update there. Is that okay?
Okay, so are people yes, Ken Bremner.
Perhaps on the comment that Mike made, it might be helpful. He made one or two of those, Claire, if we got a target in tracking to 2030, which is whatever 5, 6, 7 years away now. So I suppose the point is we don't want to leave it until 2029 and suddenly go, oh my God, we're off track. We might want something in the interim that just suggests it's getting better or it's getting worse. So maybe just expand that a little bit perhaps, and that might help board members get a feel about whether that 10% reduction, for example, on the first one, actually is going the wrong way. All it's saying is we're not going to hit the target.
Yeah, that makes sense, Ken. We'll look at that. Also, obviously, I'm conscious that we've got the integrated delivery report as well that actually provides that information too, with regards to whether or not performance has improved or declined as well.
Should be easy to do then.
Yeah.
Right, and then Jacqueline Myers, Executive Director of Strategy and Operations.
Thank you, Chair. Just to add that at the next board meeting, we're bringing an implementation plan around our joint forward plan. So that's the 5-year horizon rather than the 1-year horizon that we focused on the integrated delivery report. And I think that will help inform the refresh of the risk assessments. Thank you.
Okay, thank you very much. We move on from that item on to the reports from committees. As you all know, a lot of the work, preliminary work on the matters that come to the board is done by the statutory committees that we've established as part of our governance structure. So first of all, the Executive Committee, which is chaired by our Chief Executive, Sam Allen.
Thank you, Chair. And the highlight report covers 2 meetings, 12th of September and the 10th of October. And just want to pick out sort of 3 key points from these. The first one, we received a comprehensive update around delivery of our interim equality, diversity and inclusion implementation plan. So there are a number of statutory responsibilities that we have in the Integrated Care Board with regard to this, and also working across the system to help shape and influence diversity and inclusion, particularly in our workforce, in our leadership representation. And Hamid Matraghi, our Director of Equity and Inclusion, has led this particular piece of work, and it was good to note that we have made quite significant progress in all areas of the plan, Chair. The second one was around service development proposals. So the allocation of what's called system development funding for 23 and 24 was presented in October, and this funding is always allocated to pursue specific areas of development, and we particularly felt it was important that the resources focusing around primary care were fully utilised this year, and we did receive a paper from the Primary Care Strategy Subcommittee which set out how the remaining funds in that budget would be to be utilised, and these were approved with the request of detailed delivery plans to put those in place. And then just finally, Chair, we've adopted what's called the Integrated Impact Assessment and the plan to use this tool across the organisation, and this will help us have a tool and approach, particularly when we're considering services or policy changes in relation to equality and health equalities, and that we've got a sort of clear process as an integrated care board for that. So the committee approved the use of that tool for any of those changes proposed. It would probably be fair to say the key risk, and this links to the conversation actually we've just had on the board assurance framework, has been particularly around the finances, particularly the work we're undertaking around what we call the medium-term financial plan. So we're looking at the next 3 to 5 years for financial planning and the risks that we know exist across the system with underlying deficits. I've already spoken this morning about our plan this year. This is a deficit plan which we will make a marginal improvement on, and that 35 million deficit we will continue from a revenue perspective into next year. So we know that the resources will continue to be tight for us, and we are just coming to the final stages of developing our medium-term financial plan. I hope to update the board on that in the new year.
Thank you. Does anyone have any points they'd like to raise on that committee's report? Thank you very much. Then we pass on to the Quality and Safety Committee, and our non-executive directors who chaired those meetings, Eileen Kaner and Hannah Bowes.
Thank you, Sir Liam. So I'll begin by just pointing out that the last meeting we presented the minutes from March. Our committee took a skip in time in order to come into synchronicity with the Finance, Performance and Investment Committee, because we share an integrated performance and quality report. So here we have a bundle of minutes that relate to the meetings in July and in September. In overview, I think it's probably fair to say this is a very busy committee. I think there's 7 plus committees that sit underneath it. We were in place before some of the place-based arrangements were in place, so I think it's taken a little while to make sure that all the place-based arrangements are in situ and reporting into this committee, which they are now. We have area nursing leads who are increasingly standardising how they look in their areas to try to bring their reports to this committee so we can see the wood and not the trees, just to look for some of the kind of issues in common and some of the learning that we can understand from some of the kind of major issues that come up. I think a real development around September is we had our first patient experience open the meeting. I think because I've mentioned these are quite sort of information heavy meetings, sometimes you can feel further and further away from the patients who are at the heart of our health and care services. And so actually having the meeting beginning with a grounding in lived experience, I think has been really important to the committee. Our first patient experience reported their own lived experience around mental health need and the requirements for trauma-informed care. And then we had a patient experience contribution on neuro-rehabilitation at the last meeting. I'm going to hand to my vice, Dr. Hannah Bowes, because she chaired the last committee in November. So Hannah.
Yeah, thank you very much. We don't have the minutes available as yet. They're still being reviewed, which is why they've not been included, so they'll be brought to the next board meeting. But Neil has very helpfully pulled together a slide, which you can all see now, which just gives you a flavour of what we discussed a couple of weeks ago. I will pick up on a couple of things. So the first thing is obviously, as with all the quality and safety committees now, we're really embedding the patient story. And so we start our meeting off with that, and it sort of grounds the sort of discussion in the fact that we're talking about real people. I think sometimes when you're getting stuck into reports and looking at numbers, it's all too easy to forget that, you know, there are individuals behind this. And so that really helps us to kind of provide that framing, I think. And the topic this time was on neuro rehabilitation, in particular an individual who'd struggled with transition of care outside of hospital and into the community, and not having the sort of right support in place really, and having to actually go private to get that support in the end, which is obviously not what the NHS is there for and what it's striving to do. So that was a really powerful example. Some of the things that we discussed have already been raised today in the meeting, so I won't go through all of them. One of the main things that we looked at a cross-cutting theme actually was how best to present the information at Quality and Safety Committee, because there is so much of it, and actually how best to deliver that to us so that we're able to interpret it and use that. So we've been using, most of the reports came within a sort of an involvement and improvement theme, which actually has been really helpful in being able to digest that information, and it was recommended that that should be across all of the reports that we receive where applicable, to make that easier for us. The area quality report, I think that in itself had more than 100 pages, so that gives you an idea of the volume of information that we receive. Maternity update has already been touched on in this meeting. The IT related incidents was a big issue, so most of you are already aware of this, but it's affected a relatively small number of patients, but nevertheless the numbers sound, you know, pretty shocking when you see how many thousands that equates to, although overall the proportion is relatively small. So my understanding as a non-IT techie person is that this is mainly to do with the implementation or transition to a system, and that system not being tested at all points to ensure that the sort of feedback was correctly in place so that any potential issues could be identified. But I can already see that our techie exec will step in and probably give a bit more information about that. And we escalated that up to this board, because clearly that is not something that just affects quality and safety, but actually cuts right across to be more of a major incident. So we escalated that beyond our committee. And then most of the other reports that we received were just for receipt and update, with no kind of major risks or issues to identify at this point, but you will receive the full minutes at the next board. Thank you.
Graham, are you going to supplement the comment about IT-related incidents?
Yes, thank you, Chairman. Thank you, Anna. Just to comment on the IT-related incidents, so clearly anything that has a technology, a process or a person input has a potential for various aspects of failure. We have had a number of incidents of late, principally leading to correspondence transmission electronically from secondary care services to GP practices. I think the first of which was mentioned at the public board several weeks ago. Since then, we've had a small number of similar incidents, but not exactly the same. And what that allowed us to do is to create a bit of a framework now. So we're pulling together a system response, clearly to understand what went wrong, but the real important feature is to learn from those experiences and share across our system. I think when the recent Newcastle incident occurred, we did send out a note to all of our provider organisations to do a review of their correspondence systems. We will be reminding colleagues to do the same. We were expecting some national mandates to do that, but that hasn't happened as far as I'm aware. But we want to make sure that we learn, through the processes that Sam, our Chief Executive, mentioned previously. We are a learning health and care system, and IT has a multifactorial risk, as I said, people, process and technology. So it is part of our learning culture, Salim. Thank you.
Thank you. I'd like to just add a comment of my own on that based on my long-standing interest in patient safety. If you look at safety in other fields between the 60s and 70s, it was all about hardware in the causation, or that was the paradigm. Then, as a result of in-depth analysis of some major air crashes, Chernobyl, and the ferry disasters, it became human factors. But software has not really come under the microscope, and most pointedly came under the microscope with those two crashes of Boeing's, where basically it seems that the software was adjusted. And so I think if we're looking at healthcare and some of the parallels with other industries, we need to be very, very interested in the element to which software poses risks, and that it isn't a minor thing to adjust software or revamp it. But Graham.
Yes, thank you, Salim. And software is a key area of vulnerability, not least that it can go wrong, most likely after there's been a change of some description. So within the health and care system, there are now standards that we need our suppliers to adhere to, and a continuous process of review and support linked to those software changes. So it is very much in the current thinking, software is an area of weakness.
Okay, particularly in prescribing as well, presumably.
All aspects, and when I touch on my presentation, I will allude to some of that clinical safety. Thank you.
Are there, David?
Thank you, Salim. I think the learning that we've had from these is that these have not been the system or the software. This has been user error in the main. And we have done independent harm reviews of all of the patients who've been early identified. And that's with, because it's primary care, we've had GP colleagues, independent reviews just to ensure that actually harm reviews have been done effectively.
Okay, thank you. Any other comments anyone wants to make on that? Very important business going through that committee at the moment, especially with some of the things that we've discussed earlier. Eileen.
Just a postscript, really. I think there's something really important about the interplay of the committee sub-board, and just wanted to say that, because I attend the Finance, Performance and Investment Committee, 2 items there around infections and neonatal outcomes were raised. I was able to say that they were already on the quality and safety agenda. We get the same integrated report. I think it actually just shows the value of being in time and seeing the same information at the same time. But as the concerns were raised in one place, we were able to say they've been attended to in the previous meeting in quality and safety. So I think that just gives assurance about how the committees are now functioning together to inform board.
Thank you, Chair. It's a bit of a theme, and I wonder if we've got some more work to do on this collectively through the Board Assurance Framework, and then notably in the papers of the Quality Committee. There are various references to shortages of capacity for things like leader reviews and other areas. And I just wonder whether or not we need to pull those together and just absolutely demonstrate that we're assured that we are taking the kind of relevant actions to address those capacity shortfalls, rather than us all collectively just sort of noting those risks and concerns.
Mike Smith.
just a brief point. One of the items referenced in the paper was the establishment of a clinical effectiveness subcommittee. I think that's showed a sign of maturity of the group. Having previously sat on the quality committee, the volume of work that's covered is absolutely enormous. So the recognition that there needs to be a subcommittee structure so that the items can be given the attention and the time that they deserve is really positive.
Thank you. I think everybody who... Yes, Eileen, I want to come in again.
No, it was just the issue of capacity that Sam raised. Certainly when we were having the extraordinary board thinking about the financial allocation, there is clearly when times are financially straightened, there's always a concern that that could affect the safety and the quality of the care that we are needing to deliver. And so I think it is a really good time now to actually just, within our current financial situation, is just to be confident that we've got the capacity to do some really important work around safeguarding and the like.
Okay, thank you very much. If we could now turn to the third committee report. It's the Finance, Performance and Investment Committee, and the chair is John Rush, our non-executive director.
Thank you, Salim. And obviously you've got in the report the minutes from the 7th of September and the 5th of October, and whilst some of those points that are up there are from November, some of them from the other meetings as well. So I just wanted to talk about, first of all, the independent sector. We asked for a presentation on the independent sector, primarily just in terms of the growth of the independent sector. Because from 2019 baselines, in terms of budgets, there's been a 73% increase of independent sector costs, as it were. And this year, whilst we are looking at a budget initially planned for 71.5 million, it's forecast to be about 103 million. So that was one of the reasons why I wanted to look at it. And the things we got from the presentation is that very good turnaround times and very good, should we say, outcomes for patients in terms of what was being done. But also as well, trying to balance that up with some of the independent sector take on board things that are more routine and less complex. And obviously to a certain extent, there's an impact on some NHS services around that, because some trusts obviously operate trying to do routine with complex, and there's a big demand on that to do both. So it's a question of what was the impact potentially of all of that on our NHS services. And one of the things we got in terms of assurance was that during the reorganisation for ourselves as an ICB under 2.0, that the joining up of the contractual arrangements with some of the quality arrangements for independent sector and other parts of our, checks that we do, that will maybe start to have a bit more of a look at that. And I think from our perspective, we found that quite reassuring that there was going to be some join up on that. So that was an important presentation. Then we also had a look at prescribing, again, another presentation. And again, to a certain extent, is due to, should we say, a 13% increase in spend for us as an ICB, and that worked out around about £35 million extra for us in terms of our budget. And what we were given is that it's mainly uncontrollable price increases to do with prescribing. But from the perspective of, okay, well, there's some things that you can't control. What can we control in terms of our governance arrangements? We, again, were assured that in terms of governance, there's an ICB medicines group, and there's also the Northern Treatment Aid Advisory Group, and of course that reports into the ICB exec group. So again, we knew there were mechanisms there that were operating to try and work out exactly what was going on with the prescribing side of things. Finance, I'm not going to go too much into, other than that we obviously get the finance report every meeting, every month. We understand the risks that are involved, we get what mitigations are being put in place, and I know that David will spend some time later on talking us through in much more detail about where we are with our financial position. But again, for us as an assurance perspective, we are fully across that and get all that information on a monthly basis. The same with performance, and I'm not picking up major performance issues in this sort of short update today. But one of the things we just talked about was obviously say this inequality and impact of some initiatives. So it came out really in a discussion about patient choice, and obviously in terms of patient choice, which is great, you can make a decision, can we move elsewhere to get this? Are there some places that will be able to do this, and not only NHS organisations but independent sector. But then again, we didn't know or understand the impact that that could have on people who may be less able to travel great distances. And it's still early days in relation to where we are with patient choice and how many people have chosen to change their appointment place. But obviously one of the things is to remind people what we can offer as organisations and what we can't offer in terms of supporting people with transport. But there was just that was a discussion that we had. And then finally, just the fact that we are now taking on board, we had a sort of update about oversight arrangements, and that we're now taking the responsibility for looking at trusts, not only those that are in, say, soft intervention, but those ones now in like a much more involved intervention. That in itself is a big responsibility. And I know you talked about resources before. What impact does that have on us being able to manage that whole process as we go through a challenging time for the NHS and organisations over the next 12, 18, 24 months. So there was just an oversight really of where we got to in terms of the things that we thought were important to raise today, Salim. Yeah.
Thank you, John. Are there any comments anyone would like to make or questions? No. Well, thank you again for all the committee chairs, because I know it's a great deal of hard work that you do with your colleagues on the committee, and it's very, very important that everything that comes to us has been thoroughly dealt with, and that we have good oversight of it. We move on now to item 10.1, and just let me start by deciphering the acronym, which some people will be familiar with, but it's learning from the lives and deaths of people with learning disabilities and autistic people. And this is the annual report in that area, and our Executive Chief Nurse, David Perdue, is going to introduce it.
Thank you, Salim. The report is our first inaugural leader report for the ICB and fulfills all its requirements as directed by NHS England. So during 22-23, we had 163 reviews from the deaths of people with a learning disability. There were 28 initial reviews and 35 focus reviews. The top three causes of death were 38 people died of pneumonia, 17 of cardiovascular disease, and then 17 of aspiration pneumonia, which obviously is a rare cause of death for people without a learning disability. For the first time this year, we've done 4 reviews of people with autism. They're all men, and they're all focus reviews as the policy requires, and a very different cohort of causes of death in terms of 2 with drug misuse, 1 with cardiovascular disease, and 1 with suicide. Just to focus on some of the work that we're doing and what's supported some of the lengthening of lives, even though there's still the 28 years of difference between somebody without a learning disability and autism compared to those without, is in terms of the improvements in end-of-life planning, and then an increase in the uptake of annual health checks and flu and COVID immunisation has played a big difference. Just in terms of ongoing concern, it is around the competency and capability within the team, because all deaths require a review, but there's no new learning been uncovered. But we are looking at, as in part of 2.0, how we centralise the team. So we have all the expertise in one place, because there's obviously multiple teams at the moment with differentials in kind of how they fulfil their roles. So we have looked at that really closely. I'd just like to draw people's attention really in terms of the improvement work that the Learning Disability Network's led. So they're working with Macmillan on a national easy read holistic needs assessment, the rollout of mandatory learning disability and autism awareness training to all the health and social care workforce. So the gold standard for that is Oliver McCowan training, which is 3 levels of that. The first level is fairly straightforward, it's 45 minutes online. The second level of training is much more complex. We have to have teams of people who have got lived experience. Now we've got 3 teams who are one of the pilots for the training. A number of our organisations already comply with the Diamond standards, which is very similar to Oliver McGowan, but we are working with our providers. And as an ICB, we're only required to train people in health, but we don't think that's the right way to do. So we are supporting social care as well as health care. So we are piloting the use of the Bubble app for people with learning disability and autistic people to track their health and well-being, and then working with Skills for People to implement the Live Well programme, which promotes good health and well-being for people with learning disability and autistic people using social media. So happy to take any questions on the report.
Thank you, David. Other points and questions people want to raise? Rajesh.
Thanks, David. I think the report's really welcome, and I suppose in the actions which we've taken around annual health checks, immunizations, those are the right actions which will give us some impact over time. My question was about what is lacking in the report, given the deaths with regards to, heart issues, cancer, whatever, is that there's no reference made to the care which people with learning disabilities receive in acute hospitals. Was there any learning in that context, which we hear from other areas, whether it's CQC reports and so on, which you could triangulate with this report?
That's a really good point, Rajesh, and obviously we do look at that from a different lens. Obviously this is the work of the network, which is much more strategic. In terms of our oversight of care of people with learning disability or autistic people in hospital, we do that through different mechanisms, but you're quite right, we should triangulate it with this.
Sarah Malik.
Thank you. Thank you for that report, David. It was very insightful and a brilliant read. I particularly liked the elements at the end of the report, which is very easy read for those people that we are reaching out to and want to engage with. My observations and questions really were around identifying any pieces of work that we could do with vulnerable groups or ethnic minority. And I know there will be something happening in the background, but I think it would be useful to have a greater insight into that. And I also was curious about any research collaboratives that we were doing with voluntary sector, as well as care providers as well. My final point is just around communication. As we know with vulnerable groups, there is a way to communicate, and just to raise the importance of getting health checks done. What are we doing to engage with our vulnerable groups and their carers to ensure that there is an understanding of the seriousness and the importance of having these checks done?
Thanks, Sarah. So in terms of the first one, in terms of ethnic, minoritized ethnic communities, that's one of our key pieces of work this year, and leading into the tackling of health inequalities and early identification and prevention. So that's a work stream through the network. So very happy to have a conversation with you and feedback on that. In terms of communication, we had a great event with people with lived experience, actually sharing how they needed to be communicated with and what was the best way for us to do that. So we're going to work with Claire's team to look at some of the ways that we do that and how we simplify some of that. So when I walk around our kind of acute providers, actually it's a minefield trying to navigate a number of them. Yeah, there's some really easy signage that we can do and do things very differently. So we're just working with the trust on that.
Okay, thank you. I think we've talked informally about having a further strategic discussion on this at a future meeting. Sam, would you like to say something about that?
Yes, thank you, Chair. I was minded that one of the very first items we had as an integrated care board was listening to a group of people with lived experience with a learning disability and the impact of shortened lives through the worse outcomes they experience. And I think this is an excellent piece of work, and I think our commitment that day to that group of people was that this was going to be a really significant priority for us as an integrated care board, and therefore I think it's good to receive the annual report today. It's really good to know how the learning's been translated into actions and they're captured in the report, I think we need to make sure we have really laser focus attention on the delivery of this. And I think we should have a longer session looking really at the outcomes and really challenging ourselves on, are we shifting the dial here? Are we, are we increasing life expectancy? Are we making a difference to the lives of people with a learning disability and their family and friend carers? So we'll do that next year, Liam.
Thank you. I mean, I think it is one of the advantages of an integrated care board like ours and an integrated care system. We have 3 million people, and as I've said on a couple of occasions recently, that's bigger than about 30 or so countries in the world. So we're as big as some small countries, and a tendency for, particularly with services in an area like this, which need true integration, but also coordination and a consistency of best practice across all of the individual smaller areas where it happens. It's an opportunity, I think, to make a major step forward and try and do something really special. So we will come back, having reminded us, Sam, that this was one of our early topics for discussion when we were formed as a board, and the annual report's been a helpful marker on the journey, and we'll come back to a longer strategic discussion in the next few months. So thank you. Yes, Hannah Bowes, Non-Executive Director.
Thank you. Just wanted to say that this broadly, this was discussed at the Quality and Safety Committee in relation to secure services and our sort of admissions and discharge in that. And one of the things that I thought was interesting, again, the minutes will be available later on, was that sometimes the statistics can look bad in the sense that we're not discharging people at a rate that perhaps we would like to for whatever target we might have. But actually one of the things that was discussed was that for some people with learning disabilities or autism, actually the reason they're not being discharged is actually because they don't want to be, and that actually sort of going at the pace of the individual is really important, and that actually what we think might work in the general population isn't always actually suitable. So I just wanted to say that I think sometimes the stats that we look at can look bad, but actually when you think about the individuals and the sort of variability of people's needs, actually you realise that for some people they need a sort of different response or a longer time than perhaps we've traditionally allowed for.
Thank you very much. Tom Hall, partner member.
Yeah, thank you. And just building on the point around a strategic discussion, looking at the lessons learned. I think I might have mentioned this in one of our board development sessions, but we have a number of learning processes in place, things like child death overview panel processes and domestic homicide reviews, drug and alcohol death processes. I just wonder whether there's something about looking at common themes for where we've got modifiable factors or things that we could look at, not to dilute the issue of learning disabilities and autism, perhaps thinking about where there might be some common ground across those issues.
Thank you. Lisa Taylor.
Thank you. It was just to raise that if you are looking at a deeper dive into the learning disabilities and autism issues, we've got a learning disabilities and autism subgroup as part of our partnership programme, and would really like to link in and support you with any of the work that we can. And it includes membership from organisations you're already working with, such as Skills for People. And one last point around, just to echo that the report was really well presented and easy to read, and it brought to mind that we make all of our papers available online for everybody. Should there be something we're thinking about as a board, as doing an easily accessible version of all of the papers that we're presenting for people?
Thank you. Levi Buckley.
Thank you. Just pick up response to Hannah's point, because we, as you know, we're doing an awful lot of work around the Transforming Care programme to support people's discharge from hospital. I think Hannah's absolutely right. There are a number of individuals who will feel anxious and challenged about moving out from a hospital setting to a community setting. I think perhaps the other side of the coin is our responsibility to have stimulated the market for the right kind of supported living, to continue our work on growing the workforce so that's the right kind of support to keep people safe. And I suspect, Hannah, that part of people's reticence maybe is our responsibility to give them the confidence about those wraparound offers of support to live independently. So I think we've got some way to go. And just reflecting on the action log, Salim, again, I think we'll look in the new year of bringing a bit more detail on our Assurance Transformation Programme back to the board to kind of cover some of that ground.
Well, thank you very much indeed for the report and the discussion, and with a promise to do a lot more in this area. So thank you. And if we could now turn to item 10.2, the Integrated Delivery Report, and that's going to be presented by our Executive Director of Strategy and Operations, Jacqueline Myers.
Thank you, Chair. So, as in previous board meetings, you've got the comprehensive integrated delivery report before you. And indeed, a number of the items covered have already been touched on in the Chief Exec's report and the committee subcommittee reports. So this month, in a slight change to approach, I've got some slides to share with the board just to draw out some real significant headlines, and then as ever I'm always happy to take questions on any other items covered in the report. So these are the areas that I'm going to cover. In order to do headlines, obviously it's not a fully comprehensive look, and I think in future months we'll have a bit of a deep dive into other areas. But this morning I'm going to have a look at our performance in relation to some key metrics relating to urgent emergency care, elective care, cancer, and some mental health and learning disability waiting times information. So I'm going to start with the, I'm going to move on a little bit, urgent emergency care, and talk first of all about our category 2 response time. So as the board knows, this is one of the categories of ambulance response time standards. This is for not the most serious category 1 responses, but the next serious, so typically things like suspected heart attacks and strokes, and there is a national ask that we hit an average of 30 minutes in responding to these ambulance calls over the course of the year 23-24. Very important category for us because, I think as I mentioned before, it's the majority actually of our ambulance calls, about 60 to 70% in any given year. So as you can see from the graph there, after a very difficult period last winter, we have seen a sustained improvement in our waiting times. However, unfortunately, we're not yet getting to that 30-minute average across the year. In the first 6 months of the year, April to September, the average was 34 minutes. And the current position you can see there for October was 34 minutes and 54 seconds for the month of October. Just to give you a helpful bit of context, we benchmark this against the other 10 ambulance services in England, and during October for category 2 we were the 5th out of 11 in terms of the timeliness of our response. We've recently done a bit of work with the ambulance service to review their approach to this, and we've agreed a comprehensive recovery plan that we're working with them through a formal oversight process. And I'm pleased to say that we've seen them sort of stabilise their position after a concerning dip in performance in August, which traditionally would be one of the easier months to hit the target, because the hospitals that were over half the category 2 ambulances end up going to are typically not quite as pressured in their A&E departments as they are later in the year. And so we're watching this very carefully, but at the moment we're seeing a sort of stable performance. We do have now a plan to improve this over coming months, and you can see there that we're aiming to get to 27 minutes and 5 seconds average over the month of March. The second bit of information on this slide is about ambulance average handover times, and this is the time it takes from an ambulance arriving at a hospital to the patient being accepted into the care of the hospital. So, I mean, something in an ideal world we wouldn't be concerned about at all, but as people will know, it's been a matter of difficulty for a number of years now. There is an ambition that we achieve an average of 15 minutes with no patients taking more than 30 minutes to hand over. And although no specific objective was set for systems during 23-24, we've focused on this very closely because we recognise the close interrelationship between delays in handing patients over at the hospital front door to the accident emergency department, and then how long it takes to deliver that response time above for category 2, because clearly if our crews are waiting to hand over, they're not on the road collecting their next patient. So the current position in the northeast, in the northeast, I should say, because this is NIAS data, is 21 minutes and 50 seconds. The position in the Northwest Ambulance Service, I should note, is better than that, and they are the ambulance service that serves our Cumbrian hospitals. We have set a plan to improve this, getting to 19 minutes and 4 seconds by March, and indeed since these slides were written we've developed ambitions to go even further on that, and I think you will recall that the Chief Exec mentioned we've done some replanning, if you like, mid-year resubmission of plans in the health service since we last met as a board, and for the first time as part of that process individual hospital trusts were required to commit to a plan to improve their ambulance handover times, and we're in the process of developing bespoke improvement plans for each of our 11 accident emergency sites across the 8 trusts who deliver those services. And so we've made a commitment to work towards achieving a maximum of 15 minutes, and as part of that committing to an absolute backstock of 44 minutes. The board will recall last year we committed to 59 minutes as our backstop position, and we monitor that very closely. So I'll be giving the board a further update on that work at the next meeting. Just turning then to our accident and emergency 4-hour target, the top left graph there you can see our plan, which is the orange line, and then our actual, and so you can see that we were doing pretty well against our plan for the first couple of months of the year, but in August and September we've fallen below the plan we set for ourselves. The national objective here is to achieve 76% of patients being seen and either treated and discharged or admitted within 4 hours. The current position in October is that we delivered 75.4% against a plan of 78.6%. As part of that replanning round, we have reset our plan for the end of the year, March. We've reduced it slightly from an 81% plan to 79.9%, still in excess of the national ask. And in terms of benchmarking data, over the last few months we've remained in the top 5 ICBs in terms of the performance against the 4-hour target, but of course we like to treat those benchmarks cautiously because we're still a long way from where we would like to be. People may recall that a number of years ago it was common to be delivering performance in the 90s, and indeed even in 1920 we delivered a performance in the high 80s across the organisations in this patch, so very keen to see that improve. Again, I just thought it was helpful to share a supporting metric here, one that's perhaps less visible but very important, and this is about patients who have a delay in getting into a bed once a decision's been made to admit them to hospital. And you can see here that we have a significant number of patients waiting over 12 hours to access a bed. These are the data for the last 12 weeks. Again, pleased to say that this is a problem that's less of a problem here in North East and North Cumbria than it is in the rest of the country. However, it's still a matter of concern and something that we watch very carefully. As noted on the slides there, pre-COVID it really was a relatively rare event. 113 of these waits happening across the whole year, whereas you see here we're having between 100 and 200 now worse week there. So a real concerning metric, and one that we hope to improve upon. In our plans this year, we were fortunate to get funding up front to put additional beds into our hospital system. Rather than waiting till winter to occur, we planned those from the beginning, and I'm pleased to say that we've delivered, in fact slightly over-delivered on the additional beds that we sought to put into the system, and we hope that will protect us from long delays from decision to admit to getting into a bed over the winter period. Just going to move into the position in terms of elective or planned care, and apprise the board of where we are in terms of the very longest waiting times that we have for patients across North East and North Cumbria. We measure this in weeks. I can translate it for you. I'm sure you realise that 78 weeks is a 1.5 year wait. So that's the wait from being referred by your GP to having your definitive treatment. The national objective was to eliminate these back in March. We got close to that within the ICB, and prior to any industrial action, we were only seeing waits over 78 weeks on our complex spinal pathway. However, unfortunately, through the extended period of industrial action across the summer and early autumn, we have seen a deterioration in this position, and you can see there that as of last week we had 313 patients waiting over 78 weeks, which is obviously a terribly long time, and those patients are split between the Newcastle upon Tyne Hospital Trust and the South Tees Foundation Trust, our two big tertiary centres. We hope, if we see no more industrial action, to make very rapid progress on getting these patients treated over the coming weeks. And we have just agreed improvement plans with our organisations. Sadly, those plans don't see these numbers fully eliminated by the end of March. I have to say, I think we can go a bit further on this, and we were given a very rapid turnaround time to submit the recovery plan. At the moment, it sits at 170. That's made up of 167 patients, plus 3 risks, who are all patients waiting for corneal grafts. There's a national supply chain for access to the grafts themselves, so we'll just note those, because we're not in control of whether or not we'll be able to treat those patients. It will depend on not whether the transplant graft is available. In relation to 65 weeks, a year and a quarter if you like, the national objective was to get all of these patients over 65 weeks treated by the end of March, coming March 24, and we had a plan to all but eliminate those waits, just down to 14 complex spines. Unfortunately, again, we've seen a real deterioration in this position, again related to lots of reduced activity and cancelled operations as a result of the industrial action. So you can see there, at the moment we have just over 2,500 people across our geography waiting over 65 weeks. We've just landed a plan to reduce that to just over 1,145 by the end of March, and again, we're going to be working closely with our trusts to try and better that plan. Just to mention a couple of things that's going on in that regard, as well as obviously all of our organisations working hard to maximise the levels of activity they deliver. And it's worth mentioning that in relation to elective activity in value terms, we're on target to deliver 112% of the activity levels that we managed the year before COVID. So, you know, more than 100% recovery. Lost my thread there. Yes, so that's the activity levels. And the other two things I wanted to just briefly mention is that the Provider Collaborative has just recently approved its mutual aid framework. That's the arrangements whereby they offer patients alternatives to move to other sites that have slightly shorter waiting times. And we're also participating in the national programme of what we're calling patient-initiated choice. It's known as the PIDMAS system, and that's where all patients over 40 weeks are written to and asked whether they would be willing to travel to get treatment at an earlier juncture. And at the moment, about 4% of the patients we're contacting are expressing a willingness to move. So we hope those two initiatives will help reduce these very longest waits and help us better the plans that we've got here. Moving to cancer and the diagnostic targets, the top set of this slide looks at what we call the 62-day backlog. So the board will recall that the national standard is that anyone who's referred with an urgent suspected cancer is either treated or discharged because they have a benign diagnosis within 62 days. And what we're focusing on is clearing the backlog of patients who are already waiting over 62 days, whether they still be suspected or confirmed cancer. And you can see here, we had a bit of a peak across August and September where we went significantly off plan, but you know, slightly better news. We're starting to return towards plan. And I'm pleased to say that all but one of our trusts has confirmed that they will deliver their plan for the end of March. The one trust that's tweaked their plan slightly, North Tees, has added just 17, so that's still quite a significant improvement from them going from 115 today down to 56 by March, and still well below the national target we were set for improvement. We were asked by the national team for a backlog to achieve a backlog of no more than 861, and our revised plan is for 817. So I hope to deliver the orange line that you see there. In terms of diagnostics, I'm terribly sorry, this is quite small for the board, but looking at the wiggly lines there, what you're seeing is the percentage of patients who are waiting over 6 weeks from referral to delivery of a routine diagnostic test. There's a basket of 15 tests that we monitor here, things like CT scans, endoscopies and so on. The orange line is the percentage in England who are waiting over 6 weeks, and the blue line is our local North East and North Cumbria population. So you can see there that at the moment we're at 15%. That's a bit of an improvement, but not massive. As you can see, the line wiggles around quite a bit. We're doing quite well in terms of activity volumes, again here, well in excess of previous rates. And the national ambition is that we get to no more than 5% waiting, but by March 25, so we've still a year and 4 months to work on this. So some progress, but we'd really like to see this step up. I think we've reported previously to board, we have been fortunate in getting approval to build 4 diagnostic centres around the patch, which will increase capacity, and we've also got some additional investment going into a couple of endoscopy departments, so we would hope to see a step up in the spring in terms of level activities we're able to deliver here that will enable us to land a plan next year to achieve that 5%. And then just finally, Chair, I wanted to touch on something that we shared with the board for the first time last time, which is that bit of work that we're doing within North East Northumbria is to look at the waiting times for children and young people looking to access mental health services in general and for diagnosis pathways for autism and other neurodevelopmental conditions. What we've done, which is slightly novel in that the 18-week targets and the 65 and 78-week targets are not routinely applied to mental health services by the NHS in England, is we've looked at these waiting times in the context not just of how many people are over 13 weeks, which is the national measure, but what the length of waits are. And there are some really concerning numbers here, as you can see. So for children and young people's waiting times overall, we have 2,800 patients waiting over 2 years, and on the neurodevelopmental stroke autism waiting time pathways, we have 902 patients waiting for children and young people waiting for a diagnosis. And this is an issue that we're very concerned about and very focused on as a board, because we know that very difficult time waiting to access these services. We had a presentation to the board last time about all of the work that's going on to transform services. I think we mentioned, amongst other things, that we're looking to do a re-procurement in the spring to extend access. We've done an extensive recruitment programme to try and identify more talking therapies to support in the general waiting times. Some of the work that we're doing in the autism and neurodevelopmental pathways is that we're applying some of the learning from the physical health sector in terms of how we manage waiting lists, how we look at redesigning pathways, and also mutual aid, because underneath these headline figures there are some quite significant differences in places where waiting times are worse in some places than others. So we're looking at whether we can deliver some mutual aid to reduce those very long waits, and we'll bring a further update to a future board in progress in that regard. So then just looking at the adult waiting times, a similar picture really. We've applied those same measures. We're now got a very clear picture for the first time, not just of the number of people waiting, but the extent of those waiting times. And this will enable us to, as I've mentioned, in relation to the children, really focus on where we can look to reduce these longest waits. And then finally, on this sheet, I've mentioned the out-of-area placement bed days. So these are patients who require an inpatient admission, and unfortunately we're unable to find a bed for them locally, and they end up being sent out of area. This is something that we're seeking to eliminate, and we have an improvement trajectory, which we've never achieved zero, but we have seen a real significant improvement on this over the last few months. So I think you'll recall that it peaked at over 800 during the summer. We're pleased to say that that's coming down nicely, and this is credit to a whole range of teams, but particularly our 2 mental health trusts who've really overhauled all of their arrangements to manage their bed processes and their admission processes. And essentially one of the really significant developments is to be looking at people who are currently out of area alongside potential new admissions and taking a view of their relative needs, and also making sure that we've got high visibility in all of our discharge planning processes of people who are placed out of area, and that we're seeking to repatriate them to a place more local to their home, alongside the sort of longer term discharge planning to get them back into the community. So that's the areas I wanted to draw attention to. I just wanted, if I may, Chair, just to comment on one other thing, which is relating to the oversight arrangements that our Chair of the Finance and Performance Committee referred to. So just to say that we've been asked as an ICB to pilot leading the oversight of all of our providers on behalf of the regional team, and whilst absolutely recognise it's additional work, I think it is a recognition of the kind of quality and robustness of the oversight arrangements that we've been delivering with our providers over recent months, and so we'll obviously be taking a careful approach to that to ensure that we're able to deliver that across the whole system, but I think that's a helpful development. Thank you.
Thank you very much, Jacqueline. Comments and questions then, David Stout.
Yeah, just on your last point, Jacqueline, I mean, the ICB and yourself are to be congratulated for being given the honour and the trust of actually piloting this on behalf of the NHSE, so I think that's really good. My question really is around elective side. And under the financial agenda, my understanding is that NHS England allocated the additional resources that they've done very recently, and they've said the priority is to deliver financial balance and to deliver urgent and emergency care. Now that's a directive, if you like, across the whole of the NHS. Do you think that will impact upon us within the North East and North Cumbria, or do you think our constraints are not so much financial but operational on the back of shortage of beds, consultants, industrial action, etc., etc.?
Yeah, okay. I think we're fortunate in North East and North Cumbria that at the point where we went into the replanning exercise, we were already exceeding our plan. We were asked to deliver just short of 109% of 1920 elective activity, and as I mentioned, we're running at 112. In fact, as part of the replanning, systems have had their elective target reduced by 4% in recognition of the impact of the industrial action, and what that means is that we'll see more money flow into the ICB because, as I think we've reported previously, we're being paid on cost and volume for elective activity. So I'm really pleased to report that whilst we had a very challenging replanning round in terms of finances that I'm sure David will touch on shortly, we were able to be clear as a system that we would not reduce the volumes of elective activity that we were planning to deliver on the back of the financial constraints. I think industrial action has been our biggest trouble, and if I'm honest, I think trusts have been a bit nervous to plan that there'll absolutely be no further industrial action. Obviously, more news is flowing around that, but I think I feel, based on the last couple of weeks' levels of activity, increasingly confident that we'll see continued progress on delivering reduced weights across the winter. Thanks.
Lovely, thank you very much.
Sarah Malik.
Thank you for that report, Jacqueline, which was very comprehensive. I think just keeping on the theme of industrial action and outcomes and the impact on health and social care systems, we currently have a transport strike in our area, and I have had feedback from my patients in the past couple of weeks that they've had to cancel appointments or not be able to attend appointments, which obviously will have a further impact on our health system in terms of backlog delivery as well as NEAS impact as well. Do we have any early trajectory on whether there has been an impact, or will we be looking at that? Because obviously as a system, as an anchor organisation, that is something we have to mitigate for, isn't it?
Thanks, Sarah. I don't have any specific information on the kind of global impacts of that. It's been raised operationally, and I think some of the organisations have done some communications on it, to wit that if individual patients are concerned because of transport strikes that they can't make their appointment, they should contact the provider and reorganise rather than waiting till the appointment has passed. But obviously there will be occasions when people are not aware of the transport until the moment they need it not being there. So we'll have a look at that. I haven't picked up a huge impact, but obviously every patient who misses an appointment because of that sort of inconvenience or slot that we're not able to use is unfortunate. Thank you.
Mike Smith.
Thanks again for the report, Jacqueline. The information on waiting times for mental health services is somewhat startling and concerning. I'm looking at the data for secondary care for physical conditions. We currently have 9 patients waiting over 104 weeks, and we're in the thousands for mental health conditions, and that is worrying. I wonder whether we should include that as a core metric in our integrated performance delivery report going forward to show how, so that we can monitor that and also signify how important we consider that as a system.
Yeah, we're just doing a bit further work on some of those data to make sure they're absolutely spot on in terms of completeness and quality, but that would be the intention. Thanks.
Ken Bremner.
It's worth just reflecting for a second to you, Jacqueline, isn't it, that whilst we've got a large number of patients still waiting to get into our system, we still are the best performing system in the country on RTT, and that is by some measure. That's the time that people are waiting between referral and treatment. So although the numbers look quite large, both in terms of the waiting list and some of the times, we are still performing the best in the country on that RTT measure. It's not being officially measured, but it's still there in the background.
Thank you. Claire Riley.
Thank you, Chair. It was just in response to Sarah's challenge with regards to transport issues. I understand there has been a new deal put forward and is going to be balloted. So we are hopeful that actually the disruption will be sorted going forward.
Tom Hall.
Yeah, thanks. It was just to build on some of the comments of Sarah's as well around the potential for all these long waiters in particular to create even greater inequalities in access to health and care services. And schemes like the PIDMAS scheme, for example, where people are given opportunities to access services in different parts of the country, that's going to be accessible to people with means and resources to be able to support that, but not necessarily in some of our more deprived communities. So I guess it's just how we're watching out for that widening inequality across access to physical and mental health services in terms of long waits.
Sorry, Neil, do you want to add to that? Yes, okay, and then we'll take other questions.
Yeah, it's just to remind the board that we do have our Waiting Well project, which is still in operation, is going from strength to strength. That is focused on individuals who are on the P4 waiting list, to those who are waiting the longest. It's a comprehensive support offer. We've had 6,000 people through that now. 66% of those are from deciles 1 and 2. And it's a support package which improves people's overall physical well-being, but also is a more rounded approach. It'll links with voluntary sector and local authorities around financial support, support around housing, just to try and reduce the impact of waiting on our population. We can give further updates to future boards, but that is a very successful programme that we're running in the North East and North Cumbria.
Thank you very much. We're just, 10 minutes over now, so I'll ask Sam Allen just to make the last comment.
Thank you, Chair. Tom and Neil raised one of the points I wanted to pick up, which is when we're looking at the data, we just need to make sure that we're also looking at it through the lens of inequalities. So particularly around cancer and diagnostic, do we have fairness there in terms of particularly access? The other thing, and I think particularly being a learning and improvement organisation, I'm always looking at this and thinking about how can we improve this, and we're a very large system, so I'm also minded that when we aggregate the data up for a sort of a global North East North Cumbria perspective, we may lose some of the richness of the sort of system within systems, and it would just be good to get your reflections on that, Jacqueline, and anything we need to do as a board to help shape that.
Thanks, Sam. I mean, it's always a challenge, isn't it, because of the sheer breadth of measures and ambitions that we've got as an integrated care board to do justice to all of those in one report in 10 minutes. But we do have underneath the integrated delivery report a whole series of reports that we can develop out right down to provider, to a particular specialty, and indeed we can segment it on some of the inequality metrics. It's our ambition to develop a portal whereby board members and other parts of the health and care community can access those data in more detail, and I'll bring an update on that in future so that people can go away and delve into a question in more detail, and I'm sure ask me even more challenging questions when we bring the report here to the board, so I look forward to that. But I think having that time to look at it outside the board is the way forward for board members if they want to understand the kind of nuances underneath. But where there is a significant outlier within a mean, I would always seek to highlight that in the report as well. Thanks.
Okay, thank you. Thank you very much, Jacqueline and the team. We did spend a bit of time being more selective about and there's more work to be done, obviously, and we welcome any feedback, but essentially the holy grail of this is always to get data that gives you insights into the things that you need to have insights on. If it can do that, then we're in the right place. So continue to welcome feedback on this. Thank you. Over now to David Chandler for the finance report. David, Executive Director of Finance.
Thank you, Chair. So I thought I would do is I'll do a two-parter, if that's okay, Chair. I'll take us briefly through the finance report, but I'll also touch on the H2 submission that we've recently submitted to NHS England that Sam touched on earlier. So if I start with the report, which I'll take as read, that's the report for the first 6 months of the year, and I think that gives us that opportunity to reflect on how we as a board and how we as a system are doing. In terms of the ICB position, to remind everybody, the plan was to achieve a surplus of £32 million. At the halfway point through the year, we were just under £10 million off plan, and that was mainly due to prescribing and packages for care pressures. The prescribing pressure, as alluded to earlier, was mainly around price increases, where prices have increased by approximately 10% year on year. We were and are, as an ICB, working on that with senior leads to reduce that deficit down to break even, and I'll touch on that again, though, in the second part of the presentation. The ICS duty was to achieve the deficit of £49 million. We agreed that with NHS England with a commitment that we would try to improve that. It's okay, Debs, we're going to do that a bit later. The pressure at month 6 for the ICS, which is a combination of the ICB and the foundation trust providers, at month 6 we were off plan by £21 million. That's quite a lot of money, but I would say if you compare us to different systems, relatively speaking, that's pretty strong performance compared to the rest of the country. The pressures were mainly in areas things as industrial action, which we've been talking about, pay award that wasn't funded 100%, and the prescribing and CHC pressures, which I've talked about earlier. When we looked at risk across the ICS, so we can see at month 6 we're overspending. The forecast risk between now and the end of the year looked to be around £90 million, and that included things such as slippage on efficiency programmes, prescribing pressures continue and the like. Now I would remind members that we started the year with unmitigated risk of £250 million. So at the half year point, we were able to bring that unmitigated risk down as a system down to £90 million. That's quite some achievement in terms of a pace and a direction. And that's been done by a combination of measures, including the financial controls that we put in place at the start of the year. Obviously, in a moment, I'll talk on our H2 submission. Other financial duties, just to mention briefly, the capital allocation duty, not to spend more than our capital allocation. So we have approximately £200 million of normal capital allocations. We are underspending at this moment in time by £15 million. We expect to land that by year end, though, so no issues at this moment in time to bring to the attention of the board. We work very closely with provider collaborative colleagues in ensuring that is the case. Running costs is our fourth duty. You can see in the report that we are reporting a year-to-date underspend on running costs and a forecast underspend on running costs as well. And we expect, even with the restructuring costs that we will incur, to bring running costs down by 30% to be within budget. So last points before I touch on H2. The spending controls are in place and being oversighted by Finance Committee, CEO leadership and DOFs. That's working very effectively. The medium-term financial plan, there is, while we work through this financial year, a desire to spend more time now and more focus and more energy on 24-25 plans. The guidance we expect to be out for Christmas Eve, as well as ensuring that we've got a medium-term financial plan that demonstrates how we will get back to recurrent balance in the medium term. I said certainly I'll touch on the H2, so what I thought I'd do is just put a brief slide up on the screen. So if you can do that for us, thank you. So I talked earlier, didn't I, about where we are, and Sam mentioned the submission that we had to put into NHS England on the 22nd of November, following a letter we received on the 8th of November. And what this slide, I'll just try and bring this closer. What this slide, waterfall, tries to demonstrate is an overview of that submission, and hopefully which in a form that is relatively easy to follow and digest. So if you start on the left-hand side, you'll see that that was our planned deficit that we agreed with NHS England at the start of the year. The orange box there, you'll see the waterfall dropping down to around £140 million. And that's the unmitigated risk that I talked about earlier, that if we did nothing else and things continued on trend, and we were seeing overspend trends, there was a risk, there was a danger that we could end up with £140 million deficit by year end. And clearly as a system, we're working on that. Since the 8th of November, we received a letter. Within that letter, we received additional funding and additional flexibilities to help us get back to financial plan or better. So the first of those was additional funding, which was to help mitigate pressures, including industrial action. We received just over £46 million. I'm actually pleased to say that was one of the instances where it wasn't necessarily done on a fair shares basis. It was done taking account of the size of your system. And some of our foundation trusts go beyond our patch, if that makes sense, such as Newcastle Hospitals or South Tees. So in this instance, they got the financial, I think they got the formula spot on in terms of making sure we got additional funds because of our system makeup. There are additional flexibilities which we touched on earlier around ERF. So the changing of the baselines and the amount of money you receive for the amount of performance you do, because there was a change in baseline, a 2% benefit to our system has been recognised. We were given additional flexibilities to recognise dental and SDF allocations and slippage in those areas. So I think it's important to mention on dental, that's slippage. That is not, if you like, driving an underspend, that is slippage despite all best efforts. And on SDF, just to give some background to that, our SDF allocation, which is service development funding, it's money that is identified for specific purposes. Our annual budget is £138 million. And what we've identified for the second half of the year is slippage of around £7 million between now and the end, that we can recognise in terms of recovery. That's split roughly 50-50 between those two areas. There are, the next two blocks is a combination of measures that also help us improve the financial position, additional income allocations or assumptions that we expect to receive between now and the end of the year. And one of our foundation trusts has also identified that it's able to improve its financial position by £15 million. We offset that with a number of commitments or pressures. We just talked earlier about the respiratory hubs that we're setting up for winter as well. When you bring all these things into place, that's covered in those second or the last two blue boxes there. And what that basically means is that we were confident that we could submit to NHS England a revised plan or a £35 million deficit, which I believe meets our commitment to continue to try and improve the financial position. And more importantly, I think you can see that it mitigates an awful lot of that unmitigated risk that we had identified in the orange box there. So that gives us confidence at the halfway point in the year, although we are in November, but you hopefully know what I'm referring to there, is that we've got a lot more confidence than I use the expression. With a fair wind, we are confident now that we can deliver a deficit plan of £35 million, if not better. And we gave assurance to NHS England we will commit ourselves, we are committed as a system to try and improve that position between now and 31st of March. So I hope that's a helpful overview slide, Chair, and I'll take any questions.
Thank you, David. Could you just interpret ERF and SDF for non-technical listeners?
Which one was it? Sorry, Sim?
Could you just decipher those two acronyms, ERF and SDF, just for people listening online who might not know?
Certainly, Chair. So apologies for putting acronyms on without the full title there. It was a bit of a nightmare actually to get the slide to work for some reason. I don't know why. But ERF stands for Elective Recovery Funds. And basically, this is the additional resources that come to us to exceed, if you like, the 1920 baselines. And SDF relates to service development funding. And this is, as I say, specific funding, ring-fence monies that are allocated for things like mental health, primary care, ageing well. We're allocating certain funds. Sometimes what happens is NHS England says, if you don't spend those resources will take them back. And we're just making a bit more flexibility in those areas.
Thank you. Any questions and comments for David? Very clear report. Good report on progress, thank you. And the audit committee's been looking at this carefully, and your committee as well, John?
Yeah, but mainly the finance and performance committee.
Yeah, thank you. All right, thank you, David. And we move on now to item 10.4, which is an update on primary care access, and that's going to be introduced by Dave Gallagher and Deputy Director of Primary Care, who is also going to come into it, Pamela Phelps.
Okay, thank you, Chair. I'm conscious of the time. Colleagues have in front of you quite a detailed plan, a report on primary care access recovery. I'm going to ask Pamela to take us through some of the high-level part of that, and there's also a part that Dr Neil O'Brien, as our Medical Director, will play in this as part of the assurance to the Board, but also to NHS England. I'll just start by saying that colleagues will recall 2 or 3 board meetings ago we had a deep dive into primary care and specifically general practice, and this is largely about general practice for clarity. We mentioned then there was a national programme which I think at the time was going to be Primary Care Recovery Plan. That's changed to a Primary Care Access Recovery Plan as a national programme, and the emphasis very much on, as it says on the tin, improving access to general practice, which we know is an issue across the country but also across the North East and North Cumbria. So an update on the plan for assurance for the Board, with a promise to come back, but I'll hand over to Pamela, who will talk through the highlights of it, and we'll ask Neil to chip in, particularly around the primary care interface, because there's a key part of this, the interface between primary care and secondary care, or put another way, general practice and hospital services. So I'll hand over to Pamela.
Thank you. So the Primary Care Access Recovery Plan, as Dave says, it is about general practice in the main, the operational delivery of that. However, it does look at a wider group of stakeholders and providers that sit around general practice, and including pharmacy as part of that, one of the pillars of primary care. As an ICB, we developed our delivery plan for primary care at the beginning of the year, and the 5 priority areas was around resilience and sustainability of our services and our providers across North East North Cumbria. It included an element of access and improving the experience of our populations in accessing those services. It talks about integration, which incorporates the fuller stocktake report and how primary care and system providers will integrate together to improve, again, the experience of access to services and their health and care needs. We also have an area focusing on the enablers to delivering our priority plans, which includes workforce and development of our staff in the provider organisations. It looks at the estates and premises from which those services are provided, and the digital opportunities and aspects of the models of care and integration and service across all of those. From the 1st of April 2023, we also took on delegation of pharmacy, optometry and dentistry, and we are currently in progress with expanding the detail of the delivery plans around those 3 areas of primary care. The Primary Care Access Recovery Programme, as you can see, evolves down from those 5 key priority areas, and we are focused on the 4 main aims under the Primary Care Access Recovery Plan, and that is how do we empower our patients to improve their experience in accessing services through digital tools and interface with them, looking at the modern general practice access programme and how they transition from their current models of care to future opportunities. How do we build capacity and efficiency in the services we currently have? And how do we cut bureaucracy, which is the element of the interface with other providers, and remove that administrative burden, but streamlining the pathways of care for our populations when accessing services. And then finally, we've got the supporting deep end practices, which is a focus on addressing health inequalities and looking at our more deprived areas, but also how we build that through all elements of the services and the priority areas we have. As Dave described, the Primary Care Access Recovery Plan, very heavily from a national perspective, the inputs and outputs are focused operationally on general practice. So we focused up to this part of the year very heavily on those elements. However, as you will see in the narrative of the system plan that you were provided with the papers, there is an element of how we are looking across our whole system and what that interface is from community, pharmacies, ageing well, frailty services, secondary care and others. So this is in the round a whole system plan that we are developing as part of the programme. I'll hand over to our Executive Medical Director to cover the next slides.
Thank you, Pamela. So I'm going to just very briefly update the board on our progress on the interface work. The letter that came out a number of months ago specifically required us to report back to board in November on the progress of this work and later on in the new year as well. So the first is onward referral. Over the years, there have been a number of policies which have been implemented within our hospitals, which limit consultant-to-consultant referrals within a hospital. Now, this is for very good reason. In some cases, where, say, if a patient was seeing an ophthalmologist, for instance, and then they had a problem with their asthma, that individual doesn't necessarily need to see a respiratory consultant. They may just need to see their GP, who'll be well skilled in managing that condition. So it was encouraged that consultants pass those individuals back to general practice. Now, there are some instances, though, where it's quite obvious that the GP does not need to be involved in that pathway if an individual absolutely does require consultant care. So we're working with all of our providers to review the consultant-to-consultant referral policy and try to make it as permissive as possible to reduce any unnecessary administrative burden on general practice. An example for that would be someone sees an orthopaedic surgeon and maybe they require referral to a pain management service. What quite often we will get will be a letter back to general practice say, can you please refer this patient to a pain management service? It's an unnecessary step in the patient pathway. It adds risk that might get missed and also puts more administrative burden on primary care. So we're going to look to work as well underway, working with our providers to make that as streamlined as possible. Also, there is a baseline assessment of all of our providers on the other three aspects in here, which are providing fit notes for the full length of time someone's likely to be off when they're recovering from either a period of illness or an operation, so that they don't have to come back to their GP, and also making sure that discharge letters are clear and are copied to patients and come out in a timely way. Patients get lots of tests done in hospitals, and quite often as a GP I'll get patients coming back to ask me for the results when we didn't organise the tests. So it's just improving the knowledge of patients so that they know exactly who to go back to, and that the recall for any of these tests are established through hospital providers. And again, there's work underway. And improving the speed and ease of communication between primary and secondary care is another point which is part of that assessment. Next slide, please. The other bit of it just does feel like additional administration that is not required in general practice is where patients need to access other allied health professionals, and at the moment one of the only ways that they can be accessed is through their GP, which puts more pressure on general practice, but also delays in the patient journey. So in the letter, there's a number of areas which it's recommended that patients should be able to directly self-refer to some of these. So for equipment services, wheelchair services, podiatry. I do get letters regularly saying, can you please refer this patient to a podiatrist? And I never say no. So there's no real risk to opening up these for self-referral. And this slide just shows the progress that there is to date. What I do want to stress, though, that a lot of these referral pathways have been around for many, many years. This change will not happen overnight. There is good progress being made. We're going to continue to push it because it's the right thing for offering patients choice and accessing these services and reducing unnecessary administrative burden in general practice. I'll hand back to Pamela.
And Pamela, could I just say we're running a little bit late, so if you could cover it as briefly as possible. Thank you.
Absolutely, thank you. What we wanted to do was just highlight some of the other main areas within the Primary Care Access Recovery Programme. This is a demonstration of multiple elements of income and investment into general practice currently. So we are trying to scope out the opportunities of maximising all investment to support the delivery of the Access Recovery Programme. However, it is a challenge to target all of these elements of funding into the right place when we want to tailor that, and we have fed back to NHS England about how we might use funding and investment more flexibly to support the needs and the tailored opportunities we have across North East North Cumbria. This slide gives an overview of the communications. So we are drawing on the core Here to Help campaign, how we communicate with our populations and service users around accessing services. And the slide on the left shows the opportunity of changing the model of access in general practice through the programme, away from that 8 a.m. rush and patients getting caught in a loop of not understanding how to access a service, but how this programme aims to streamline that access and speed up the outputs for the patient. There is multiple elements of support for general practice throughout this programme, and this slide gives you the current status, although it is slightly out of date because we've done a lot of work to improve this, and we've had many practices. I think there is 60 practices who've accessed the intensive quality improvement processes, and we've got a general practice improvement programme. The cloud-based telephony is well underway to change the analogue systems to digital for, I think it's 58 practices now across North East North Cumbria's phase 1. So this is all about improving that experience of patients when accessing services. This final slide is just an overview of the timelines and expected activities across the 2 years, which is a 2-year programme till March 2025. I must say we will come back to board in March with an update if that's acceptable to board, and then further board reporting in the 2nd year. From a financial perspective, one of the main actions we are doing is currently to understand the impact of this transformation exercise on us as an ICB moving forward, and how we need to plan financially to invest in the positive outcomes we aim to deliver through primary care access recovery.
Thank you. So we're required with this item to feel assured that progress is satisfactory, and to be aware that we're going to be getting another report in March 2024. On that basis, are there any questions or comments?
Thanks, Chair.
Rajesh.
I'll be quick, and it might be that the comments might be reflected in the response which they bring back in the new year. But I just kind of 3 quick questions or comments. I mean, it's a really good paper, lots and lots of details. And I think the improvement work around older people, urgent and emergency care, elective recovery, all is great. Whether any thought has been given as to how that could also be looked at in the context of a medium-term financial plan over the next few years, because it kind of links through pathways which goes from primary care to acute services and so on. So that's the first point. Second question was, there's a lot of reference being made to the Fuller report, transformation. Absolutely wonderful to see it for the first time as to how that would be worked through within our region. But there's no reference made to community transformation for mental health. And basically both those programs are very similar with the principles, and we are missing a trick here if we don't incorporate that and get that all together. So that might be something else to reflect on when you bring the paper back in the new year. And the final question would be, again, to think about how does this link with the clinical strategy of the IC.
Okay, thank you. So if we could ask that those are picked up in your ongoing work and we hear about them again in March. Dave.
Yeah, and Chair, just to very quickly pick on the Fuller point, and this is the risk of using shorthand when we have reports. So by Fuller, we're talking about a fully integrated way of working, and Rajesh, for assurance, that definitely picks up mental health. We did have Claire Fuller actually on Patch last week, and she was listening to progress being made in County Durham, which actually includes, as you know, some impacts around mental health. So absolutely, it's in there.
Syra?
Thank you, Sir Liam, and thank you, Pamela and Dave, for that comprehensive report, which actually acknowledges the breadth and plethora of work the general practice has to cover in our healthcare system. Just a couple of reflections and observations, if I may. The first was around one of the key enablers being estates. Obviously, if we don't have an area from which to deliver primary care, we'll not be able to do anything. So I know that the LMCs are working on estates in general practice, but if I could appeal for any support from the ICB with regards to estates, that would be very helpful in helping move matters forward quicker. Talking about access, I mean, obviously we've done very well in the North East North Cumbria area. We have a population of just under over 3 million, and yet we deliver 1.48 million appointments in general practice every month. So that's nearly 50% of our population being seen every month in general practice, which is quite an achievement, particularly with being post-pandemic and the problems that we've had. I welcome the modernisation of general practice. I do applaud that we look into population health and health inequalities and digital poverty. You know, we should, of course, be reducing any access barriers to primary care and getting the right care at the right time by the right professional. But I'm just also conscious, as no doubt Tom will back me up here, that obviously there are barriers that we need to consider when we consider that. And yes, thank you.
Thank you, Eileen. Okay. Thank you. Well, thank you to Dave, Pamela and Neil, and we look forward to returning to that subject in March. Oh, sorry, Christopher, go ahead.
Thank you, Celine. Really excellent report, and some of the items really welcome is the consultant to consultant. It's going to make a huge difference to some of the inquiries that we receive from patients all the time, and the longer fit notes, and also the expansion of the self-referrals is going to be really helpful. I can say the impact of that. The only thing that I want to highlight is something that I'd fed through the Patient Voice Committee, and it fits in with the vision around trying to empower patients, and it's a concern around community pharmacy, bearing in mind what's happening around some of the supplementary hours around pharmacy. So it's just to be aware that that could impact on the success of it.
Would you like to respond to that, Dave?
Probably only to say that one of the advantages of actually us now commissioning pharmacy, optometry, dentistry is we can join those dots up a little better, and working locally with health and wellbeing boards who've got responsibility for pharmacy needs assessment. I think we're in a better place to manage that. But yeah, I recognise the challenges and the constraints we've got, Christopher. Thank you.
Thank you. Well, thank you very much. I'm sorry that was a little bit rushed, but we're covering a lot of ground this morning, and we look forward to hearing more about it in March. And then now we're turning to an important item to be presented by Graham Evans, our Executive Chief Digital and Information Officer. We wanted to start to explore the implications and the opportunities of artificial intelligence for healthcare. And Graham's going to take an early look at the subject.
Thank you, Chairman. So as the Chairman suggests, this is a very high-level overview of the use of artificial intelligence, or AI as it's abbreviated. Starting off with some broad definitions, I'll then touch on the use of AI in everyday life, moving towards how AI is being used within the healthcare setting in a scaled-up manner already, and then some ideas and opportunities where AI is moving in towards innovations and new ideas that could then be scaled in the next 3 to 5 years. I'll conclude my presentation with some ideas and opportunities that we're looking at within the North East and North Cumbria. So AI, by way of a broad definition, is about computers or machines that mimics the capabilities of the human mind. Interestingly, the mathematician Alan Turing, who many colleagues will remember led the Enigma code-breaking team at Bletchley Park, would have suggested that AI were systems that essentially act like human beings. And the reason I mention Alan Turing, colleagues will be aware that in the recent weeks, the Prime Minister undertook a UK summit on the use of AI and used Bletchley Park, where Alan Turing operated from during the war years. So it's really apt that the father of modern day computing is still being talked about in modern applications of technology. One of the most exciting areas of AI is a technology called generative AI, or Gen AI. Gen AI is about technology that utilizes essentially predictive language that produces then a range of outputs, primarily text-based, could be audio, video. Most notably, the technology that we are familiar with today is a technology called ChatGTP. The GTP acronym stands for Generative Pre-trained Transformer, and I had to read that because I'm not quite sure what it actually means. But one of the more widespread uses of technology in the AI field is what's called traditional or analytical AI. And that technology actually uses computational algorithms to produce outputs such as predictions, analysis of various data sets, including structured and unstructured data. Both traditional and generative AI are very different, but they do complement each other. And in fact, generative AI can feed traditional or analytical AI and produce quite a nice, comprehensive set of AI capabilities. So the intention or the expectation is both of those technology platforms will coexist into the new world. So many people talk about AI in fairly high level and general terms. AI is not to be confused with RPA, which is also robotic process automation. Those technologies are principally used to automate human tasks. For example, making sure that you can analyze data quickly and use those tasks to almost create human-like activities. AI is more about the computational capabilities, acting, as I've said, more like a human mind. Some examples of real-world applications include speech recognition. So AI is used quite widely where we take language, spoken language, and convert that into a range of text outputs in terms of written formats. Customer services, many of us would have used or been accessed or interfacing with some of these technologies, commonly known as chatbots. I'll just go back to speech recognition because one of the areas that people are probably most familiar with are the use of Alexa and Siri. Other platforms are obviously available, but that's an area that people will be familiar with. Computer vision, this is a really interesting area. Some of this is used now for things like number plate recognition, facial recognition, and where it takes digital images and combines that with artificial intelligence computation to render new ideas and outputs. Something that many of us won't get too involved with is automated stock trading. So if you were on Wall Street using some of the more traditional routes to identify if your stocks and shares should be invested in or divested, AI is now running quite a lot of work in those areas to really speed up some of those decision-making processes within the financial sector. Some examples of AI use currently in health and care. Keeping well, and just picking up one of the points that Neil, our Executive Medical Director, mentioned, where we can look to identify where people need to be managed in a safe and secure area whilst waiting for some form of elective treatment, putting the patients or citizens in more control of their own health and care, a phenomenon that we've referred to as shifting left, how we can move the sort of responsibility back towards the consumer. That's an area of rapid growth and utilisation. Where we can use AI in early detection, so identifying, people deteriorating in various aspects of their healthcare, and their disease types such as cancer and so on. AI has a really major part to play there. Diagnostics is also a similar environment where, looking at the use of AI in some of the ologies such as radiology, pathology, analysing vast amounts of data to support clinicians in some of those clinical decisions, etc. And that leads to the second point, the penultimate point there, in terms of clinical support and decision making. And then treatment, how AI can prompt clinicians based on some of the data that it's analysing in a patient's healthcare record to then prompt and suggest appropriate treatment plans for the individuals concerned. An interesting area is the use of AI perhaps in end-of-life care. And we know clearly that people are living longer, but now living longer with some health-threatening conditions. And often that's quite a lonely place. AI in this particular case can help people feel less isolated by using technology such as avatars to provide support to patients during those end-of-life phases. Research, the use of AI to speed up drug manufacture and the research required behind that. So it reduces the time to market, but also potentially has a cost benefit. If we can get drugs to the market and tested quickly, it can clearly have a benefit for the people and populations that we serve. And then training, a really interesting area of adoption where technology can be used to prompt trainees, but also access a large amount of research data and actually create more informed responses during the training process. And again, it's quite an area of quite new development and adoption, but has a massive potential in large-scale areas of development. Apologies. Some specific examples that we're using around the country, an interesting one being looking at how we can use risk stratification in healthcare. C2 AI is a technology that's risk stratifying patients in some parts of the NHS in England, drawing on the organisation, the C2, if I can just refer to my notes, if you bear with me, colleagues, because I did make a note of that and I can't remember what it said. Copeland Clinical is the C2 reference. So Copeland Clinical were an organisation that had a history of doing clinical audit. They've developed some AI capabilities that now can look at risk-assessed patients, their mortality status and so on, complications, and look at how we can identify deterioration. Again, links to the concerns of how people can wait well. But if we can identify those patients most at risk, and then their solutions have an opportunity to then create some prompts and nudges for clinicians to intervene where necessary and appropriate. There's a major push of this technology, particularly in the Cheshire and Merseyside ICS, where they have started to implement some of this technology as far back as September this year. Similarly, another type of AI is machine learning. It's not as complicated as traditional analytical or generative, but some of this type of technology can be used to assess clinical applications such as radiology, x-rays and so on, to make sure that prompts and clinical decision support can be delivered. Rotherham, who are looking at this already, are also trying to expand into all areas of their clinical services. Health Navigator, again, this provides some high-level system-wide risk stratification, looking at how they can rapidly identify patient cohorts. And again, there's an area, Staffordshire ICS are doing some sterling work in this particular area, how they can then prompt resources such as health coaches to intervene early and help people have a more healthier outcome in their care services. And there's a similar one, pinpoint data science, again using machine learning for multiple blood analytes, again bringing in a large amount of various data assets to diagnose particular health conditions such as cancer and so on. Some other examples include the use of computer vision and AI. Interestingly, researchers at Moorfields Eye Hospital are looking how they can use some of this type of technology in their ophthalmology services. But as well as identifying some of those health conditions, it can have secondary benefits to identify other potential health challenges such as heart attack, stroke, Parkinson's disease. And I was just reflecting on one of the updates earlier this morning with the announcement of the new eye hospital in Sunderland. Again, this may be an opportunity to build into the new ways of working, given the technologies evolving at such a rate of knots. And then clearly, predictive analytics is a major area. If we can start to predict rather than react with particular health challenges, you know, the use of some of these type of technologies, and Pangea data is a particular area that's leading the field in this particular area of research. So again, creating a rich picture of a patient's healthcare conditions, accessing a multitude of different health data sets can then provide more accurate diagnoses of particular disease types, you know, current or perhaps predicted. So this is really just a summary of the whole range of services that AI are helping with currently. I'm not going to go through this list verbatim, but diagnostics, we are doing quite a lot of work regionally now as part of our diagnostic services to introduce some of this type of work. Predictive analytics, once we've got a really good solid base of analytical data, start to use artificial intelligence across the top of that to start to do some real world predictions. And we know that colleagues in our commissioning support services have already started to adopt and adapt some of these technologies. Virtual health assistants, again, using some of the sort of front end of our supply chain, using chatbots and avatars to really reduce some of the human administrative burden that we're all facing. Electronic patient records, this is really linked to aspects of our regional provider digital maturity. AI has a major part to play, but it is dependent on having those solid and robust foundations in place. If organisations are not electronic in their healthcare provision, the use of AI won't work very well, if at all. And again, I've already mentioned the use of AI in some of our administrative tasks. If we can start to sort of use technology to reduce some of the human burden, we can really start to drive some efficiency across our health and care systems. So as well as the opportunities, there are also implications. And referring to the chairman's remark earlier about software testing, we know that there isn't a large research base of AI testing currently, so that's an area that we do need to consider building in. Although there are things such as the digital technology assessment criteria, those standards do exist, but it hasn't really caught up with the new world of artificial intelligence. So there's some work that does need to be done there. And again, I've mentioned, whilst automation may reduce some of the human input, there is a worry that the automation of healthcare systems could dehumanise this care and service that we provide. The other challenge is, as we become more dependent on technology, there is a risk that we de-skill some of the clinical work that takes place. And conversely, we will need to upskill clinicians and other practitioners to use new AI tools and capabilities. And finally, the fact that AI consumes a lot of data, there will also be some concerns by members of the public in particular about where that data resides, what it's being used for, etc. So there are some concerns that will be managed, but we just need to walk before we run. And I'm hopeful this piece of technology works.
Until recently, AI has been much less actual intelligence and more number crunching. The potential in healthcare, but we need to understand both the risk and benefits in advance of adoption.
Just using a piece of free software called Synthesia, which is on the screen, really just to demonstrate that we can really create some outputs fairly quickly with quite novel use cases. So there are some related AI opportunities in the region. Colleagues may be aware that recently a combination of a number of our provider trusts were successful in a bid for a percentage of a £21 million lung diagnostic AI program. So that's really going to benefit the people and population that we serve. There's also been an ICB-led program linked to spirometry. And we do know from recent conversations, certainly within the executive committee, that there are some some areas of opportunity and challenge there, but if AI can be used, it could perhaps balance some of those resources. So that's quite an interesting development. Within GP and primary care environments, there's already a piece of work to look at the use of AI to act as a triage capability, conscious that some members of our population are not digitally connected. There is a big challenge with digital poverty. So we just need to make sure that we don't disadvantage people by offering these solutions. We will need other alternatives as well. The ICB several months ago signed up a support letter to Northumbria University to develop a whole range of research linked to citizen-centred AI, and a number of our other universities are now moving in a similar direction. So as well as the health service benefit, there's a massive amount of opportunity and research taking place within our own region that we can be part of and help shape the future of. And then finally, an area that I only found out about last week, but this is a real opportunity for our region. One of the challenges that we have, colleagues will be aware, not when people are admitted into hospital, is getting them repatriated quickly and safely. One of the challenges within that process is the development of discharge summary letters. And that's normally left to some of our most junior staff that are overworked. AI is now being considered as an opportunity to gather a lot of that data, and even traditionally discharge letters should start at the point of admission, but AI can now take over quite a lot of that work and do a lot of the heavy lifting, as they say. So the ICB is being invited to perhaps consider how that may operate at a system level. It will be dependent on levels of digital maturity within our member organisations, but the next step will be to create a bit of a summit where we'll bring clinicians together to do a bit of thought showering, as they say, get some ideas on the table, and then assess the opportunity and value in doing something like this. But it does feel as if it's a real opportunity that we could embrace together as a system. So finally, AI is rapidly becoming part of our everyday lives. We know that it can do a lot of the things that humans do, but a lot more quickly and a lot more efficiently. The potential for AI within healthcare is immense, just like in our everyday lives, and we do need to make it part of our everyday activities within the North East and North Cumbria healthcare system. What we will need to do is to create a plan, a strategy and an approach to make sure that this is coordinated and delivers the value that we need. Chairman, I'll end there and hopefully answer any questions that are offered. Thank you.
Thank you. That was excellent, Graham, and we look forward to returning to that subject. And I hope if the discharge letters, I've had a lifelong campaign against discharge letters, which are very common with elderly female patients that start by saying, "this pleasant lady." So if the AI can get rid of that, I'll be very pleased about that. Okay, so Lisa, you're going to start, please.
Thank you for that, Graham. That was really interesting. Obviously, the community and voluntary sector is a really big part of our system, made up of a lot of completely independent organisations. We've also started looking at AI. We held our VON conference on AI just a couple of weeks ago. Is there any plan to include the voluntary sector in being part of the system as we move forward into this brave new world?
So Lisa, the short answer is absolutely. Colleagues within the board will be aware that we're about to do some work to develop our broader digital data and technology strategy. A subset of that will be the creation of an AI strategy, but we do need to understand the opportunities across our system, from local healthcare providers, local authorities, voluntary sector, third sector, academia. So we'll be starting a bit of a summit to get the thoughts and ideas together. So the answer is absolutely, and we'd welcome that support. Thank you.
Rajesh.
Thanks, Graham. Excellent presentation. And I think the question was related to your last comment about the plan and the strategy. And I'm sure you will reflect on it, but it would be useful if, whenever you bring it back, whether you could look at how that links to the ICS strategy. And predominantly the three big areas there: inequalities, clinical condition pathways, and people. And obviously that links to the financial plan again. So, but I think it's a really, really good opportunity. But amongst that, also, what would be the low-hanging fruit? What we could do in the next year or 2 years? So yeah, but maybe it would be a board discussion at some stage when you have enough time to reflect on it.
So at the board development session, Sir Liam, I am going to present the opportunity around our digital data and technology strategy. The latter part of that is about AI and how we can work along the lines that Rajesh suggested. So that will be part of that process. Thank you.
And then finally, before lunch, Sam. Oh, sorry, Mike. No, go ahead. Go ahead.
Just briefly, thanks, Graham, for a really clear presentation. I'm truly excited by this technology. I think it's going to be revolutionary. I think there will be a necessity for significant investment, though, in the short term to get these things implemented, because much like we know with large-scale IT projects of any kind, they work, especially in healthcare, to make sure they're implemented effectively and safely takes a lot of time and expertise. And that's going to be the real challenge we've got to be able to gain the productivity advantages that will come from these, is it will require a lot of hard work in the short term to get operationalise.
Thank you, Mike. Sam.
Thank you, Chair. I just wanted to share that enthusiasm, but also a note of caution. ChatGPT, for example, it's a language model, it's growing daily, and it's growing based on what people are putting into it. So it is already developing inherent biases. And I think anybody who's using it needs to make sure that what it's telling them is actually the fact. And I think the investment that we need to make is looking at things like enterprise licenses, so that for our own staff, our own health and care system, we're providing a more protected environment whereby we aren't just feeding a language model that's developing on a global footing, but something we can control more and have those safeguards in place.
Well, thank you. It's been a busy morning. I'll give you the 5 minutes that we've lost for an extra 5 minutes at lunchtime. So if we could please be back at 1:10. Thank you. Welcome back, everybody. Next item 11 is our strategy for children and young people, and David Purdue, Executive Chief Nurse, is going to introduce this item.
Thank you, Sir Liam. It gives me great pleasure this afternoon to go through our strategy for children and young people, and I'm ably joined by Kath McAvoy-Carr and Heather Corlett, who runs their Children's Health and Wellbeing Network. It's been my great pleasure to lead children and young people services since joining the ICB, and I also lead children and young people services on behalf of NHS England for the North East and Yorkshire. We've got a clicker. Heather. Next slide, Heather, please. So just in terms of context, in terms of better health and wellbeing for all, one of our 4 key in our 10-year integrated care strategy for the region is better health and wellbeing for all. And then there's a key focus in our joint forward plan, which sets out the NHS delivery aspects of our strategy. So obviously one of those is giving children and young people the best start in life. So in terms of giving children and young people the best start in life, it's enabling them to thrive, have great futures and improve lives for generations to come. And in terms of those outcomes, partnership working and integration is key to this. So it values the work that all our systems do for children and young people's health and well-being. And as part of their network, we have 4 not clinical leads, we have service leads. So we have people who lead the network, who work in the local authority, who work in the voluntary sector, who work within safeguarding, and then in health as well. So I think it's really important that we have that breadth for children and also for education. So we cover the whole areas for children and young people. So in terms of our priorities, as I said earlier, mental health and wellbeing for children and young people is one of our key priorities for that. And we have a number of objectives that we want to achieve, and that's improve access to mental health support in line with national ambition, to reduce reliance on inpatient care, whilst improving the quality of inpatient care for those who need it, and then really importantly, skill children and young people and the workforce to support mental health and resilience. When we look at long-term conditions for children and young people, prevention and the effective management of long-term conditions are key to improving population health and the burden of ever-increasing demand for healthcare services. So there's some excellent transformational work that happens through the system, including epilepsy, diabetes, asthma. But integration centres to drive innovation through our most disadvantaged communities, including areas relevant to long-term conditions, is really, really important. Then we've got around complex and vulnerable and special educational needs and health inequalities and the impact of COVID. So the impact of COVID on our children and young people is well documented. The core 20+5 is a national approach to reduce health inequalities. But specific consideration will be taken with the inclusion of young carers, inclusive health groups and other socially excluded groups. In terms of our objectives for this, it's equitable recovery of elective waiting for children and young people. And we focus a lot, like on adults. And today's board again showed there's a focus again on elective recovery, but we don't split that into children. And actually the children's waiting lists are growing rather than getting better. And deliver children and young people's core 20+5 framework, and then meet our regulatory framework for good practice for SEND. And we've had a number of SEND inspections now in the region, and we are looking at how we share that practice across. And then we have the best start in life, so preschool needs and perinatal services. And that's really important around our objectives of connect, especially with place and local authority partners, and then initiatives that skill children, young people and the workforce to support the best start in life, preschool needs and perinatal mental health. So there are kind of key objectives of what we want to achieve. And this just shows you in terms of our populations across our places, with an average of 20% of our population being a child or young person. And I shall pass you on to Kath.
Thank you. Oh, I'm going to have to do my clicker myself. You had somebody to do that for you. No, don't worry. Just very quickly for myself, just to give you a little bit of a context of what the data is telling us for the North East. So children represent approximately 20% of our population. They are obviously 100% of the region's future health outcomes. And as we all know, deprivation in childhood is significantly impactful on outcomes for our children when they become adults. And poverty levels within our region are really significant, and we are almost top of the league tables that we don't want to be top of, and lots of local authorities and local areas are doing work around poverty and trying to understand or trying to mitigate against the impacts of poverty, which does include a regional poverty action plan, which is being led by Amanda Bailey, who is from the North East Child Poverty Commission. We know that school readiness by the end of reception is a key indicator as to children and young people's early years development, or children's early years and development, and it's a good indicator to evidence the impact of some of these challenges. And we also know that the promotion of health equity in childhood is absolutely essential, not just for moral reasons, but also for ensuring that as a society we have good economic and good economic growth in the future.
Good afternoon, Chairman, board members. Thank you on behalf of the Child Health and Wellbeing Network and its core team of staff and our rich network of part-time advisors that David's already highlighted for inviting us today so we can talk about delivering the Children and Young Persons Strategy. It's been a privilege and a passion for me to represent the network since 2018. That's actually 4 years before the publication of the strategy that David highlighted. So that meant that we were really well placed as a region to feed in the views from our network's 2,000 member reach in the development of the strategy to either validate its content and indeed encourage and lobby for it to be updated. Our early establishment is a real
bonus, I think, for our region. But it was the foresight of Professor Chris Gray, the former ICB's medical director, and Ben Clark from the Clinical Networks, who presented the need for a continued focus on children in a gap between policy. And it secured the clinical leadership of Dr. Mike McKean to establish a network. You will, I'm sure, agree that it was the fabulous passion and vision from Mike as clinical lead that set us on a trajectory of partnership, delivery, and system representation, putting us squarely in the integration space, the sweet spot where magic happens. I highlight these points of consistency in relation to consistency between policy and funding and integration at the start of our talk today, because these elements, I believe, has enabled us to work within children and young people to enable them to flourish and provide assurances to you on our progress in the child health and wellbeing system to address the huge challenges they face. They in turn become the elements that we mustn't lose, and we must progress and implement the strategy with both consistency and integration in mind. But the first slide must be from the young people themselves. So I'll play a clip that was created during a young person's recent sprint for our Healthier Together programme, which you'll hear about later. It was made on their phone, unprompted, during the session. What a fun and energising piece of media, and what amazing skills. I've spoken about how I feel privileged leading the network that represents such vibrant and exciting young people. But they view the world differently to most of us in the room today, as their experience in life has been so different too. So to represent them and to look to improve the challenges that they face, as we know, is a huge responsibility. I'm cognizant of this, and it might not come as naturally to me, because I'm now 3 decades past when I could qualify as a young person myself. So the breadth of the child system is so wide. It includes health, local authority, voluntary sector professionals, and the delivery of multiple statutory responsibilities from different organisations. Education has a huge influence on our young people's lives and has a place of safety, security, learning, peer support, creative enabler, and one of the 4 areas around positive mental health, along with family, community, and the individual. Board members are aware of the importance of integrated working across the sectors to support children in unison. This vision acknowledges the benefit in working across organisational boundaries to enable young people to thrive. A system-wide network with its near 2,000 membership reflects the numerous professional groups and sectors all playing a vital role in our children's development. To ensure the voice of this system is heard and understood, the network has developed over 40 advisor roles to support them in health, voluntary sector, education, local authority, and roles focusing into integration and health inequalities and looked after children. Our vision was clear: to enable children to flourish through partnership, working with a clear ask to share good practice, connect them to the many experts across this broad system. The breadth and complexity, of course, does not stop with the professionals. The young people themselves are so different from birth through childhood, adolescence to young adult. They have different needs for service delivery and how we engage as well. At every interaction with children and young people, we need to consider the family too, which is where the board will be aware of the importance of a family lens in the wider work that it delivers. An example, when looking at mental health, data developments and strategy. We've heard from David the key elements that focus is being given in the children and young person's best start in life goal. There were mental health, long-term conditions, health protection, vulnerability and complex needs, and preschool and perinatal. Well, we can instantly see here in our priorities wheel the alignment of the priorities that were developed in 2019 on the back of feedback from over 1,000 young people and professionals. Even pre-pandemic, mental health was the #1 priority highlighted by both the professionals and the young people. Number 2 for the professionals and 3 for the young people was poverty, a huge driver of inequalities, and this early focus has again enabled some innovations that have been developed further and of interest nationally. We also have the enablers and cross-cutting themes with our broader reach within the network. The pandemic had a massive impact on our young people, and none of us could have realised. So we revisited our very new priority wheel back in the early days and had a further 400 system responses. And with that, it asked that system support, the blue piece of pie there, that was an enabler, was brought up into the priorities, acknowledging the huge impact that family support has on children and young people. These priorities were system defined, and the network still focuses its work into these areas, which includes the key areas under the ICB's Joint Forward Views Best Start in Life section. I'd like to acknowledge the huge amount of work at place and across partners to deliver services that support our children and young people in the North East and North Cumbria in delivery. What I will share with members now is a focus on integration through our network with some examples in relation to each of the top 10 priorities listed in the green on the right hand side. This is quite a stark quote, but necessary when considering our responsibilities to our young people. It speaks to the lost voice of children as a Cinderella service in an adult-dominated system. But I share this quote from Getting It Right for Children and Young People from 2010, which had 39 recommendations that I'm sure many of you have worked to deliver, and that Kath, as our DCS lead, noted the positive establishment of the safeguarding partnerships set up from this that are still in place. Whilst a lot of work has taken place since 2010 to climb the mountain of challenges we need to address, there have been further setbacks for our young people that board members are well cited on: the increase in mental health needs, poverty rates, impact and influence of social media, dangers of vaping and changes to mortality rates, and of course the impact of the pandemic. Children were seen as the collateral damage, affecting in particular mental health needs, loneliness and isolation, safeguarding, socialisation and development, speech and language delays. The mountain of challenges got higher, so the voice is our #1 priority, both in the wider system as well as in the co-production and co-design sense. So it's from this starting point of disadvantage that, and the description of a Cinderella service could still be fitting in 2023, but we are working to address this both through NHS England, national colleagues, local executives and teams throughout our network by promoting the voice of young people in our work and our services. As the report from the COVID inquiry highlighted, it's important to listen to what children and young people have said about what they want from their childhoods and, where possible, incorporate their voices into decision-making processes. Board members will understand the real challenges to genuine involvement and co-production, augmented in our young people needing different methods for different stages of development and needing young person relevant methods to engage meaningfully. Colleagues in local authorities have a long history of effective youth voice, including Children in Care Council and Youth Parliament, and voluntary sector partners have fabulous in-reach services to reach our most underserved communities. What I can share with board is some of the evidence of our engagement. We have given it priority. We have a youth board process meeting ahead of our executive board and feeding their views directly into our board discussions. We have developed a network of over 50 groups registered to give a broader reach of youth organisations representative of the many communities and reaching across the system to local authority and voluntary sector settings. We're working to ensure our young people are seen and heard. We have 3 apprentices posts. Adam, our current apprentice, is shown in the middle of the picture here. Our youth board are developing a manifesto through visual arts to define what they would like from its relationship with our executive board. Using the relational toolkit work in partnership with Newcastle University. The 2 pictures on the right-hand side are from the other weekend, and we're very excited to see the outcome from that manifesto. Our improvement work has youth voice within it. For example, our asthma schools accreditation requires evidence of a young person's involvement in that process. The orange box on the side demonstrates what integration, or at the bottom, the impact of integration and how we've started to share the thread from the original importance and how it's demonstrated in the examples today. Mental health is the highest priority of all challenges identified by both professionals and young people. Here are some statistics identifying the challenges which board members discussed at your last meeting when your Executive Area Director highlighted the increased need and focused response to address it in this area. It is a known global issue and has a strong correlation to poverty. OHID, our Office for Health Improvements and Disparities, noted its importance for North East and North Cumbria in its recent Children and Young Persons Mental Health Data Pack, highlighting the important risk and protective factors, the individual, the child's family, the child's school, and the community the child lives in. These factors are within our broad network community and incorporated in our approaches that I'll highlight. Finally, our poor mental health constitutes a substantial disease burden and drives further health and social inequalities in adulthood, which I'm sure you're all aware of. This important priority is clearly highlighted in the Joint Forward Plan and the strategy, and there is much work and focus into this area. Through integration, we have progressed work to complement the higher tiered support into lower level needs in education and training. Our youth mental health first aid model, funded through our NHS Charities Together bid, and which was a cross-system bid, and a model that support and train our voluntary sector colleagues already working into our most vulnerable young people. Again, working in partnership, access direct into those communities. The second important area is partnering through other networks. We've historically had executive level contribution from the Mental Health Clinical Network, and we work to develop new ways of working as their role changes. Another example of extremely successful ICB Always the Right Door event, where it was promoting trauma-informed work with children and young people. It had over 200 people in attendance and service user and family involvement at its heart to drive forward improvement in this critical area. As a network, we were able to advise and support and connect in that event. And I just want to share the collective actions that were agreed. The 2 most popular on that day was the need for more integrated teams and posts across the sectors to include voice of children and young people, families and carers, and that young people should lead and design services and be involved in the commissioning processes to decide how best money should be spent. As we try to bring together our mental health and physical health components that as a system we have siloed, I'm pleased to also highlight the important work to facilitate the mental health champions in acute settings and the work within our long-term conditions workstream progressing mental health initiatives, as we know it's our children with long-term conditions that suffer from up to 4 times the levels of mental health need. The orange box again articulates some of the integration benefits of this work, including the community model impact direct to those most in need through our 11 youth mental health first aid instructors
that have trained over 600 people, ranging from parents to support workers, teachers, health workers, including dentists and service users. I've spoken about the breadth of the system, which is integral to supporting children and young people, and our work to come together with partners to enable more children to thrive as the driving vision of our work to succeed. The other reference to breadth is the breadth of influences and the impact on our children's outcomes, the wider determinants of health. Poverty was the second highest priority that professionals and third highest for young people when they identified the priorities. The powers in the amazing system that identified the needs, as this was ahead of COVID and the devastating data that's been published since 2019. On that statistic, we can see the increase has now affected 51,000 additional children. That's 1,033 classes of 30 children more are living in poverty. Members will be aware of the correlation between deprivation, health and life expectancy, but that lifelong sentence has been shown to take root in early years. So the importance of impacting our children and families living in poverty and the barriers they encounter is vital. This shocking statistic could also illustrate the correlated increases in our current and future services, the cold home impact on respiratory services, and the Institute of Health Equity highlighted mental health as one of the key outcomes of living in a cold home. As a result of this, the priority of our integrated focus work into communities facing high levels of deprivation started in 2020 with a dialogue with our young people and families. We asked them, what are the barriers to coming to health services due to poverty? And this has led to a new innovation, poverty proofing in the health settings, with a voluntary sector partner, Children North East, and a finalist in the Health Service Journal 2022 as a most impactful project addressing health inequalities. We're pleased that this innovation is now in its fourth iteration in our region, and it's real evidence of the impact of integration and working together and some of the magic things that it can create. And as Kath mentioned earlier, both our network and more centrally our Director of Children's Services colleagues are involved in the emerging strategy and action plan for the North East, facilitated by North East Charities Commission and the Institute for Public Policy and Research.
Heather, sorry to interrupt you. You're on 3 out of 10, and I'm worried that we won't have any time for discussion. We'll have all the slides, so we can have a look at it. If you could speed up a little bit, that'd be very helpful. Thank you.
Of course, I will. Thank you, and apologies. So here we can see some of the initiatives that have been delivered in relation to poverty, and this is through one of our partner networks, the Diabetes Network. In particular, the poverty proofing, that was the first time that it was tested out, but also diabetes access to technology that started with an introduction with local authority in the south of our patch and has led to, by the end of October 2023, 199 families have been provided with a repurposed mobile phone, laptop or SIM card to facilitate access to diabetes technology. Additional needs and vulnerability. There are clear focus in our strategy and include the many groups of children and young people with both physical and mental health needs, and also from the inclusion groups that we've mentioned earlier. There's much work in the region taking place, in particular in relation to the neurodiversity pathway. And as a network, we've been able to feed into this work as well. So following on from the Mental Health Clinical Networks Foundation, then we have continued this important strand focusing on family needs and supported by Claire Devaney-Glynn and the parent lead and advisor to the ICB. This has been in recognition of the reach of the network and the ability to engage the required partners across the system. Colleagues may be aware of the various programmes of work that are undertaken across the system by partners with respect to diagnosis, triage pathway and the provision to support children and young people and families. Inequalities in access are threaded through multiple strands of our strategy, so important that they are recognised. And I also recall how the children and young people commented specifically on their ability to access services. Within the network, we have developed the national Core 20 +5 programme and given it a North East and North Cumbria lens. Through the support of the Healthier and Fairer programme, our health inequalities and migrant health advisor roles could continue, and we've developed a toolkit to support organisations in relation to health inequalities in children. It takes the national area of focus that is seen here in the middle, which looks at asthma, epilepsy, diabetes, oral health and mental health, but we overlay a North East and North Cumbria lens on the wider determinants that we've already know it's so hugely important to children. They're clearly listed in the bottom line of the visual and encapsulate the challenges we've highlighted to date. I'd just like to note on this slide that we've had 605 downloads of the toolkit with 350 related website activity. Apologies if the diagram in the orange looks like it's 3,500 downloads of the slide, of the framework. Strong Start in Life. It's the title of the 4th goal, but I love this quote because it defines that the first 5 years will actually shape the next 50. Many of our partners are already working into this key area, and I wanted to highlight one of our sharing good practice our sharing good practice toolkit that we have, which is a huddle, and we presented a huddle on baby boxes. These boxes are filled with great resources to support new families and give babies the best start in life, with some practical resources to make sure that poverty isn't a barrier to development, as well as supportive instructions and invitation to facilitate play. Families have been reported through the Children's Foundation that they felt more prepared for their baby's arrival with the support of the box, more supported, it made them feel happy, and the items in the box helped them bond with their baby. We also, at that same huddle, shared the information on the Down Syndrome North East baby box and have since been associated with Theatre Hullabaloo Let's Play baby play pack. Health promotion, the breadth of our system, I think highlights the importance of making every contact count, and I know as a board you often reference that. Through the network we're developing an alliance to support the children and young person system, and so I felt it was important to highlight this as a key tool to enable the breadth of the system through a formal route of an alliance. I mentioned earlier that family support had been added since the pandemic and brought up into the priorities area. It is very important to the development of children and young people. And the Children's Commissioner reminds us that as a society we need to think family more. We have a fabulous initiative in the South where we have brought together our arts and creativity as a cross-cutting theme, and you'll see there it's been shortlisted for various awards. What this has done has brought a new sense through its partnership as a dance initiative, as well as offering family support, that those families are taken into a new creative environment, and then when the offer of family support is held up, they appear to engage in a different way to standard statutory services. And so we're looking at the research in this as to understanding why, but it's really interesting that through this creativity it brings a new element and a new rapport as a result can be created. Childhood illnesses, the long-term conditions we've highlighted throughout the work today, the importance on the long-term conditions, and here I've focused on our asthma work, and I can give assurances to the board on the progress of all the children and young persons transformation national asks. but we know that emergency admissions for asthma are largely preventable, so I'd like to share the work that we've been doing in the North East to address that. So building on the foundations of our North East innovation Breathe by Dr Townsend at the Great North Children's Hospital, the funding of the NHS Transformation Programme has further developed and extended the reach of this work across our region through our education-based interventions delivered by our community and pharmacy advisors. We're also successfully delivering across the wider aspects of the programme. We've seen some great results and our focused energy directed into this important area. We have asthma advisors in schools, we've got Beat Asthma Friendly Schools accreditation, we have schools policies that have been downloaded over 600 times, we have resources specific for schools and housing colleagues, and even a podcast that was the most downloaded in the national annual Ask About Asthma event. The fruits of the labour, the improved workforce confidence and competence with over 1,600 people taking up the training, 91% of whom are in education, and we're starting to see a reduction in hospital attendance based on September non-elective admissions. Although September is a known spike, there is a sustained year-on-year reduction since September 21, with a huge 65% reduction in hospital admissions for the same time frame. Whilst we cannot say this is solely attributable to this work, the progress made and the known fact that they are preventable admissions is hugely encouraging. One of the final initiatives I'll now mention is from Data and Digital. This quote highlights the high attendances we see in urgent emergency care for young people, especially those from deprived areas. What we have in the purple is a quote from a young mum in a project about how effective our Healthier Together initiative has been to assure patients the right course of actions and changing behaviours from attending A&A. The Healthier Together programme commenced in 2022 and has a strong national support and has been funded to date by the Transformation Programme and the North Eastern Yorkshire Digital Primary Care Fund. We work closely and we'd like to thank the ICB Executive Lead for Data and Digital for his support and strategic planning of this work. The funding's enabled a small core team to develop a North East and North Cumbria specific content on childhood pathways and guidance on how to support the unwell child. It includes access to other innovations such as the Newcastle Gateshead CCG Little Orange Book. We're pleased to say 5,500 children in our region are registered on the app, and they are from 300 different practices. We have nearly 30 practices signed up to receive the online consultation and are working with our ICB communication partners and primary care colleagues to encourage more practice take-up. The website continues to grow, and month on month, its peak of 45,000 hits during 1 month due to the Strep A outbreak last December illustrates both our ability to provide a responsive platform in times of need as a valued, trusted resource. Regular usage is about £12,000. I'd also like to note in this that the digital poverty position is a really important one that the website and the app are tackling through the facility Recite Me to translate and give accessibility tools. The app has an online function that can be used to check symptoms without Wi-Fi access. We're working with Healthier Together champions, and we've reached over 10,000 young people and families using voluntary sector organisations in the communities. We also have are supporting the production of hard copies versions of the Little Orange Book for the under 5s. This slide summarises some of the challenges highlighted today and the mitigations in place. An interesting publication looking at the history of integration in child health talks about the challenges of the oscillation of innovations and funding. I've demonstrated what we've built from the original ICS foresight to improve the consistency between policy and the benefits of working in the integration area. The first 5 years depict the next 50 years. So having the best start in life as one of the 4 goals is vital. Whilst there are a lot of work progressing with the increasing challenges, the mountain's getting larger for us to overcome. Thank you for your time today. I'm a general nurse with improvement and engagement expertise, but I'm powered by the most amazing team of 6, a fabulously experienced network of child health and wellbeing experts and unique young people that they serve. I hope you heard their voices and hard work. I leave you with the words of Sir Al Ainsley Green, a real advocate of our network. Thank you.
Well, thank you to Heather, Kath and David. Open it up now to comments and discussion. Maybe I could start. There's a formidable range of things that have been happening and are very, very impressive. But if you focus entirely for a minute on the outcomes that you want to improve, where are the early wins? So if we came back this time next year, where would you be confident of showing improvements in health outcomes, whether it's, or, I mean, numerous examples given, but whether it's something, if you like, largely, usually not a high priority like oral health, I know it is in your strategy, or control of diabetes, or some of the other things. Your early wins.
So I'll start. I think in terms of long-term conditions, I think the work that the network's done, especially around asthma outcomes and diabetes outcomes, are really impressive. And I think there are ones we can see. I think from terms of the best start in life, we saw some really great information yesterday around school readiness, which is one of the outcomes that we can see. So we work really closely with public health. And so school readiness, we are above the curve in the northeast, despite having real high poverty levels. So that's one of our outcome measures where I think we are really keen to progress, and the data is there. And so I think they're the kind of 3 for me, Salim, in terms of where we are.
Yeah, oh no, it's a good example because when I went round, or nearly finished going round the ICP area chairs, Mark Fryer in Cumbria had that as one of his priorities, but he was having difficulty with it, a lot of difficulty. Is there anything we can step in and do to help him to boost his performance?
Yeah, absolutely. So I'll link in with him because obviously the data that we have for public health is just for the northeast. I know kind of, so we'll ensure that data's shown through to him as well.
Okay, thank you. Eileen.
Thank you, Chair. Firstly, thank you, Heather, for the great presentation. Just to say, I was there before the integrated system was there as working with Mike McKean in the Great North Children's Research Community all of those years ago. So it's wonderful to see it develop. In terms of the early wins, I shared some information with you, Salim, a few weeks ago, in terms of some work we've done and published, which has followed children up from essentially birth up until 17 years of age. Now, a lot of people say poverty, what can we do about that? And why is it, is it an issue for our health system? What we've been able to show through longitudinal data is that you can see outcomes for children's mental health at age 14 and for their behavioural outcomes at 17. So you can actually sort of see real impacts of the first 50 days lasting for the rest of children's lives. And an early win is in supporting maternal mental health. So it is these children facing multiple adversities. There's poverty, they're in challenged housing, there's sometimes violence in the household, can be substance use and mental health difficulties in their parents, but usually the primary carer, which is often a mother. So I'm going back to the integrated women and girls health hubs and just thinking, bringing strategies together is where you find opportunities for synergy. And one of the areas to support children and young people is also to support maternal mental health in those early years for the children.
Thank you. Lisa.
I just wanted to say thank you to Heather for the presentation and to everybody for the work of the network, particularly on the emphasis of partnership working. I think it's a really good example of where differences between sectors have been used to support the advancement of shared objectives. and all of the work that you're doing is driven by the needs and the wishes of the children and young people, of our children and young people. I just think that's absolutely fantastic. Thank you.
Graham.
Thank you, Chairman. Heather, thank you very much for the really detailed update. Just a quick question that has sort of two elements. How do we compare our work with other integrated care systems? But I guess more importantly, given the great work that's happening here, are we sharing our work with other systems? Thank you.
Thank you, Graham. I think I'd like to say that as an ICS, and with the development of the network ahead of the ICS's development themselves, we're really well placed, that we had a strong awareness in our region already. And yes, we have shared our practice indeed. When the new ICB executive leads were appointed, myself and Mike McKean did a presentation to them on one of their first meetings when all four of them came together across the North East and Yorkshire. So I think we do. The Healthier Together app and website nationally, that's been picked up, and they're adopting that. We went the first in the country. It's been designed and developed from Southampton, but we are, I think, the second in the country to take on the app, and we've had discussions with national colleagues about our experiences because they're keen to spread it. So I think we have a lot to be proud about in the North East and North Cumbria, and a lot still to do. Thank you.
Thank you. David Chandler.
Yeah, thank you, Chair. I won't repeat any previous comments, but I totally support and agree. I was just wondering, in terms of the number 2 priority was around mental health, and just thinking about our performance figures that we were discussing earlier in the board meeting. In terms of one of the slides, there was a slide that talked about 85% of children finding support from families and friends, and the value of first aid training. So my question is, given we do have a service development fund for mental health children and young people, and we have a mental health investment standard, so my question is, do you think we're putting enough money, and do we have enough support services in place around mental health first aid training for not just children, but for families as well? Would people know where to go to get that accredited training in the North East? Would be my main question. I'll do that.
Kath, do you want to take that?
Yes, I do. So the answer to that would be always, no, we're not putting enough money into that, as you would expect me to say. But there's a couple of issues for me. I think we, across the system, we're starting to see an increased pressure in relation to referrals coming through that relate to mental health challenges or mental health issues for our children and young people, and equally relate to mental health problems of parents as well. Because there isn't enough out there to be able to deal with that massive influx. And Eileen, I was taking on board what you were saying there about actually maternal mental health. And in our family hubs, we are investing in maternal mental health support, because actually we recognise that this is a critical issue for us, particularly during pregnancy, but actually beyond pregnancy as well. So I think the wider that we can get those mental health champions, or those first aid mental health champions, the better for everybody, really, because actually it's about that earlier intervention which will stop that continual growth in the numbers of children and young people who are needing to access much more formal support. So yes is the answer to that question.
Yes, Heather, go on.
Thank you. And just to add to that, from the network's perspective, the Youth Mental Health First Aid project has come to a close with the funding that it had. We are actively seeking further funding, and we believe that the model that is directly into those communities that Kath's talking about and delivering to the families and the young people themselves is definitely a way forward and has a great impact.
Sarah.
Thank you, Sir Liam. Just a question for information and a bit of knowledge upskill for me. I don't know whether it's placed better at Catherine. But I was just wondering, obviously, when we talk about the adult world in terms of medical outcomes and evidence-based medicine, we attribute 85% of health outcomes to be wider social determinants of health, and only 15% is based on health service provision. Is that still the same for children? Do we have enough information to hold that understanding, or are we looking at something different?
Anything? Yeah. I never know whether you've got your... It's like being on Teams, the yellow hand, I can't tell what's happening without that. There we go.
I forgot to take it down, but I just wanted to return to Syra. Firstly, to say, yes, indeed, and the information that I'm going to send to Kath, which I had shared with Chair, actually points to essentially wider and social determinants driving physical and mental health difficulties in children, not just in and around early life, but in their teens and into young adulthood. And then I also wanted to make a point about some of our local authorities who've recently been awarded funds to develop themselves as health determinants research collaborations. So Newcastle and Gateshead and South Tees, plus one more to be announced soon. This is where local authorities have got £5 million of investment to build their capacity and capability to drive evidence generation about what they do and what they're doing with partners, very much focused on wider and social determinants. So the inequality agenda is written right through that. So it's a bit of good news on top of lots of challenging stuff.
Well, we'll circulate Eileen's paper. Let's get that round to people. But we need to stop there. But thank you very, very much. It was a very interesting session, and we'll look forward to revisiting it. Claire, are there any questions submitted from members of the public?
We don't have any questions, Chair. However, I would like to just mention that we have received a letter from Keep Our NHS Public with regards to the process in which questions are asked at our board. We will respond to them directly and make sure that the response to their letter is put online.
Okay, thank you very much indeed. Is there any other business? If not, that concludes our meeting, and thank you everybody very much for your participation, and particularly to the presenters who gave us some really good food for thought and discussion. Thank you very much.